Hi everybody. So welcome to the first video that I'm actually recording for this new project. I think Dermat is a subject which is very high, very scoring, and in most exams you get around 4 to 5 questions, and it is very possible to get all of them correct. So the video is going to touch upon the most important aspects that you need to know from Dermat, and if you can master this much content, you are good to go, right? So like every video, the flow that you study any subject would be: you master this video, do active recall, do the flashcards, then go on to the MCQs of Dermat, which are one step ahead, right? Anything which I have covered in this video, I will not include in the MCQs. So the MCQs would either be an application of the content here or would be one step extra, right? So that's how I have triaged all of the content. That video is must know, which includes most of the previous year questions, most or all of the previous year questions, and any potential question which may be asked. So it is pretty exhaustive, and you can master this, and you are good to go for Dermat, right? So let's dive in. We'll divide it into various sections. We'll start off with a few basic facts about skin. We'll talk about papillosquamous disorders, infections. Skin infections including leprosy, sexually transmitted infections also are the most important. So if you have to master one topic, it's sexually transmitted infections, because it spans across Dermat, PSM and OBGY. So that's why that's the most important. Then you have vesicobullous disorders, particularly important for INICT, and in the latter have few miscellaneous images. So very image heavy. You need to build a pictorial memory for Dermat, right? So enough introduction, let's start. So we start off with the basics of the skin. So the skin is made up of epidermis, dermis and hypodermis. So epidermis, this has been asked previously, is what is derived from the ectoderm, surface ectoderm, right? So that's pretty obvious. Exceptions are two, and exceptions are what's gonna get you questions. So when we talk about melanocytes, we remember from ANAT, melanocytes are derived from neural crest cells. Motel passes is the mnemonic. So this is what is derived from neural crest. Langerhans cells are a part of your reticuloendothelial system. Everything in reticuloendothelial system comes from mesoderm, right? So you can also correlate how spleen and in the brain microglia are also exceptions because they come from mesoderm. So reticuloendothelial system as a group, you can remember, is always an exception, comes from the mesoderm. So everything else in the epidermis is ectoderm. Going on to dermis, so we divide the dermis into papillary and reticular. So the superficial dermis is called papillary, deep dermis is called reticular, right? So papillae, the dermal papillae are superficial. So that's how you don't have to memorize it. So this is your mesoderm, and this is also PYQ, dense irregular collagen. So here these derivatives are questions and dense irregular collagen is a question. So I'll put a question wherever it's a PYQ. So dermis, if you just read it, it's in the name, it's dense irregular, so we don't have to memorize it. And you have hypodermis. So hypodermis is mesoderm again. So that is where you have subcutaneous fat mainly. So epi and everything else is meso. So this is the first topic. Now let's talk about the unit here. So we have a pilosebaceous unit. Pilo meaning hair follicle, and sebaceous gland which opens into it, and you also have a muscle here, right? So that is what leads to hair getting pillow erection is what you call it. So that is your pilosebaceous unit. So this is where you have sebaceous gland which opens in, and this is what has been asked many times as an image based question. It's a holocrine gland. Holocrine gland means the complete cell is released as secretions. Okay, so that is what sebaceous gland is. It is a holocrine. So that's just a quick anatomy integration. All right, so it opens into the hair follicle. Another thing that opens into hair follicle is this sweat gland. So the sweat glands which are related to the hair follicle are apocrine. So let's talk about sweat glands. So apocrine sweat gland needs hair follicle to open. That means, where is it located? So this is what is located in two places, groin and axilla, and these are two places where this sweat is associated with odor. So that is what is responsible for body odor, right? So now when this apocrine gland is blocked because of overproduction, what happens? What is this axillary finding? So this is what happens when apocrine gland is blocked. So this is what is called as Fox Fordyce spots. Don't mix it with Fordyce spots. What are Fordyce spots? They are present in the lips. How I remember is lips, upper lip, lower lip, whatever, is one structure. So one word. Fox Fordyce disease, not spots. Fox Fordyce disease, we have two axilla, right? So how not to confuse? Axilla do hai, two. So Fox Fordyce, Fordyce, one lip. Okay, so this is what is Fox Fordyce disease, obstruction of the apocrine. But when you have inflammation, secondary inflammation of the apocrine gland, now you have these discharging sinuses. So this is your buzzword here, that when you have these discharging sinuses in the axilla, you have secondary bacterial infection. This is what is hidradenitis suppurata. As the name suggests, suppurata, it's inflammation, right? So these are two conditions with apocrine gland. The sweat glands which directly open into the skin surface, these are eccrine sweat glands, right? So they do not need hair follicle. So the first point, they do not need hair follicle. They are directly opening onto the skin. Means they are present everywhere. For example, palms and soles, no hair. So we still sweat. What is the gland? Eccrine gland, right? So now when eccrine gland gets blocked, when you have very hot humid areas during summers, what happens? Prickly heat, right? You must have seen Dermicool ka ad. So that's prickly heat. And what do we call that? That is called as malaria. So malaria are these, lesions which develop because of overproduction of sweat by the eccrine sweat glands, right? So that's what is called as malaria, which also has stages. In the initial stage, you will see vesicles. So that is malaria crystallina. Very apt name. Looks like crystals. If it gets inflamed, it becomes red, malaria rubra, and very inflamed profunda, right? So the names are pretty obvious, no need to memorize. Crystallina, rubra means red, profunda means profound, right? So that's malaria, which is a disease of eccrine sweat glands. So this is about some anatomy here on the sweat glands. What are modified apocrine glands? So modified apocrine, everything is in the name. So you have MA. So MA matlab mammary. So breasts are modified apocrine glands is the most important information here. Then see MO, modified, that is Moll's glands. Moll's glands are present in the eyelids. And then you have C for ceruminous, right? So memorize right here, right now. Think of the name, modified apocrine, mammary, Moll's, ceruminous, right? So this is what we need to remember here. See, any piece of information, you divide your content into two things. One, you understand. If you understand, you don't have to memorize. That's the best part. If you know the why, you don't have to remember the what. That's the rule. So wherever there is a concept, we understand. For example, these exceptions, right? We understood them. So you don't have to memorize. Then when there is something which is just fact, no concept, modified apocrine hai to hai, how do you bring a concept? So there you find a trick. So if you can just do two things, and that's my attempt as a teacher, to either explain you the concept or give you a trick to remember. So in the end, you just remember the tricks, right? And you are good to go, because concept you are not going to forget. So that is the aim through these videos, right? So this is where now you will know ectopic sebaceous. The good part is, if I know modified apocrine, I don't have to memorize these, because ye ho gaya. When you have two tables, master any one, right? So ectopic sebaceous are everything other than these three. So no need to memorize the list, but let's go through it. So Fordyce ho gaya versus Fox Fordyce. Montgomery tubercles present in the areola of the breast. Meibomian gland and Zeiss gland. Both of these are present in the eyelids. In ophthalm, we'll study meibomian. So meibomian gland inflammation is chalazion, right? And there's one question there, recurrent chalazion, what do you rule out? You rule out sebaceous cell carcinoma, right? So it's all, everything is a blob of information. We just have to bring it together. So that is why in chalazion, we rule out sebaceous cell carcinoma, right? So I'm just going to write chalazion here and you will understand it. And Tyson's glands in prepuce. So these are all sebaceous, but we remember this table. Done. So now we go on to the layers of the epidermis. We said epidermis derived from surface ectoderm. Let's go through the layers now. So you know the topmost layer obviously is stratum corneum. You know that there is no nucleus here. So this is stratum corneum. Then the lowermost layer has to be stratum basal. That makes sense. बीच में क्या है? In between we have legs. So you'll remember legs. So L for lucidum, G for granulosum, and S for spinosum. Right? So no need to create any stories. Remember corneum basal and then legs. Right? So this is about the layers and their arrangement. Let's see what is there in different layers. So in the stratum basal, we have all of the keratinocytes, right? Everywhere in the skin, you have keratinocytes. So what happens to a keratinocyte? It is proliferating in the stratum basal and then it goes up. This process of going up to the corneum takes around 28 days. It spends 28 days here, then it's shed off in 28 days. So this total process, which is called as epidermal turnover time, is 56 days on an average, right? But in psoriasis, this becomes 56 ka 5 to 6 days, becomes very, very short. So because of that, what happens now? If you do 56 day ka syllabus in 5 days, you agree there's going to be a lot of accumulation, backlogs. So that is why in psoriasis, we see hyperkeratosis, which is thickening, and parakeratosis, which is retention of nuclei. We will discuss that further, but remember that and why that happens. So now going on to the different cells. What lives in basal are the two M's. So one, you have the melanocyte. Can you see the cell who has these dendritic processes? So this is what is a melanocyte that distributes melanin to different cells. To be precise, one melanocyte gives melanin to 36 different keratinocytes, and that's called epidermal melanin unit. 1:36. Now, what happens when you bring numbers together? 6, 6 and 6. That's all you have to remember. So even if you forget, vaguely you remember ki 6 tha. So 56, 36 and 6, right? So that's how numbers come together and you can remember them easily rather than, having spread them around here and there. So this is what is basal. Then we also have Merkel cells. So this will study neuro. It's a sensory receptor, slow adapting sensory receptor. So this is what is Merkel cell. One extra point about Merkel cell, cytokeratin marker. So the cytokeratin 20 and 7. These are two cytokeratins we use to differentiate different things. This fact, I have forgotten at least 20 times. That's what you remember. Ma'am keeps mixing this up. At least 20 times she has mistaken this. So 20 bar mistake karke, ma'am has learned this. So CK20 positive. So I've learned this after making a mistake 20 times. That's how you remember it. So CK20 positive, 7 negative, right? This is not important, but what is important is that Merkel cell jaisa hi, just like Merkel cell, we also have CA colon. So CA colon has been asked that they were liver mets. When we did a biopsy of liver mets, it showed CK20 positivity, CK7 negativity. So what is the primary? It's CA colon, okay? So this is about Merkel and melanocyte. Then we go on to spinosum. The very word spino means spines, means acantho. So this is where you have acanthocytes, the cells connected through intercellular connections. Hence, acantho is the word. So acanthocytes, or in these spinous processes, you have desmoglein, which is the intercellular connection. So now, in what condition do we have antibodies against desmoglein? That is pemphigus, right? So in pemphigus, you have desmoglein antibodies, autoimmune condition. So that is why, do you agree there? What am I going to get? I am going to get acantholytic cells. Instead of having spinous processes, those spines are lost. Similarly, same thing happens when you have herpes. We will talk about herpes, but there we see Zank smear. In the Zank smear, they'll describe acantholytic cells. So that's another pointer that we want to remember. Just pemphigus, just like pemphigus, is staphylococcal scalded skin syndrome. So staphylococcal scalded skin syndrome is also where, we have desmoglein, which is getting attacked by the toxin. So that's also one other cause of acantholytic, but we will link these two, very soon. So that is what you have to remember. Apart from that, what also connects, apart from just desmoglein, are the calcium ATPase channel. So calcium ATPase is also responsible for these connections. So where is this lost? This is lost in two diseases. So one is Darrier and one is Haley. So in Darrier and Haley as well, we can see acantholytic. So this is one question. Acantholytic cells are seen in all except. So very conceptually. Okay, pemphigus जैसा ही staphylococcal scarlet skin syndrome, Darrier, Haley and herpes, right? So that's what is important. In addition, in HSV, you will also remember ballooning of cells, right? So ballooning, acantholytic cells, Zangsmere. These are a few buzzwords for HSV. Going to Langerhans. So Langerhans cells are your antigen presenting cells, right? Part of reticuloendothelial system, mesoderm. So let's talk about Langerhans cells. So with Langerhans, you need to cover LCH. Langerhans cells, histiocytosis, proliferation of these cells. This is where on electron microscopy you see these granules. Does it look like a tennis racket? Yeah. So this is what are called as Burbeck granules, tennis racket granules. Let's do the CD markers. So Burbeck granules is CD207, which is Langerin protein, right? So that's CD207. 200 series mein ho gaya. From that go to S100. Through S100 now go to 1. So 3 markers, 100 and 200. Like that you can remember. 1A, 100, 207. All 3 are positive in LCH, right? So that's what is the marker of this Langerhans cell histiocytosis. This is something that presents in children. So you have a typical triad called as Hand, Schuller, Christian triad. In the name itself, there are 3 people. So don't remember that. Let them remember. You remember triad ka naam has triad. So Hand, Schuller, Christian triad. What does it include? So you have proptosis, because there is proliferation, behind the eye, proptosis. Then you may have diabetes insipidus because it can affect the pituitary stalk. And you may have calvarian lesions. So there are lytic lesions in the skull. So calvarial skull lesions described as, geographic lytic lesions, which I'll show you in radiology as well. So geographic lytic lesions, proptosis, diabetes insipidus, this is the triad of LCH, frequently happens in child. You may also get rash, you can get hepatosplenomegaly, everything else is non-specific. So that's why this triad works, right? So this is how you will diagnose Langerhans cell histiocytosis. Through that, let's take one tangent. So S100 is also a marker of melanin, right? So anything which is of melanocyte origin, like a melanoma, you can also see S100 positivity. In addition, there are 2 more. One is HMB45 and another is melan A. So obviously melan tells you melanin, so they'll not give you that. S100 non-specific, so they'll not give you that. So the only takeaway here is HMB45 is a marker of melanocyte origin, right? So this is about spinosome. Then going on to granulosome, as the name suggests, there are granules. There are 2 granules. First granule, also called as ordeland or lamellar body. Second one, keratohyalin. So ordeland or lamellar body is what produces lipid, right? So lipid or oil emulsion. Because of that, our skin is moisturized. What happens if this is not there? We are gonna see asteatotic eczema. So this is where the lipid component is not there. Steatoria. Steato matlab fat, right? So fat in the stool, steatoria. So asteato. Makes sense. No need to memorize. Keratohyalin granules contain filaggrin. So if this filaggrin is not there, filament aggregating protein, if this is not there, again your skin is dry. So dry you have scales. So many scales, the skin looks like fishnet. So this is ichthyosis. So ichthyosis is a defect in filaggrin, right? So that's done. Lucidum, not important, only in palms and soles, and there are these granules of eledin in it. Stratum corneum, already done. So these are the layers. Now let's go to dermatopath and understand a few terms, right? So this is just one more image. Let's see. This is the stratum corneum, lucidum very, very thin. This is granulosum where you do see some dark, granules. Rest of it is spinosum and the lowermost is basal. So how to approach this, histopath image here is, You can see basal. Basal to niche hi hoga. Granulosum you see as dark granules, and the topmost non-nucleated layer is corneum. Just fit the other two in between. So that's how you have to approach these images, because they can ask you, any disease with respect to the layer. So these can be A, B, C, D, and then I can make as many questions as I want, right? So let's understand all of these terms and where they are seen. Hyperkeratosis. What was hyperkeratosis? Thickening, right? So hyper was thick, thickening of the stratum corneum. कहाँ पे मिल रहा था? Where were we finding it? So this is what was seen in psoriasis, right? So particularly in psoriasis. What was parakeratosis? Parakeratosis was nuclei retained in the stratum corneum, also in psoriasis. Now, what is orthokeratosis? It's an unnecessary term, really. So, this is where you have hyper but not para. So, how I remember this is orthopedicians are very hyper. We'll join this, we'll cut this, but they're not para because they're cutting stuff. So, ortho is hyper but not para. Where is this seen? Definitely not psoriasis, because you're seeing both. So that brings us to lichen planus. So lichen planus only shows us hyperkeratosis. So that's orthokeratosis, right? So in lichen planus, I can either write only hyper or I can write only O ortho, right? So that is lichen planus for you. In addition, are there other causes where I can find parakeratosis? Yes, so you can remember peas, but even if you don't remember peas, remember not lichen planus, because that's the question. That para is seen in all except. So we already know the answer. Let's just do the formality of remembering other options. So we have psoriasis, eczema. Chronic eczema will lead to parakeratosis. Then A for actinic keratosis. We will learn this soon. It's a pre-malignant condition. Scales, actinic keratosis, and squamous cell carcinoma. So anywhere where you have scales, you have, thickening, this is peace for you. Dyskeratosis. Unlike, what you might think, it's not dysplasia. This is premature keratinization. So premature keratinization is dyskeratosis. Where do we see dyskeratosis? First of all, D for D, Darier's disease, the one that we did under acantholytic cells, the same Darier's. Where else? You also see this in actinic keratosis. So pre-malignant lesion and squamous. So obviously pre and malignant, both of them are going to lead to premature keratinization, right? Then we talk about hypergranulosis. Where do you have hypergranulosis? This is again lichen planus. So lichen planus, we did not give it para, right? We didn't give it parakeratosis. It's like you have to give me one more thing. We're like, okay, you thicken your granular layer. So that's what it did. And this is what is responsible for the Wickham stria that we see in lichen planus, right? So that explains the Wickham stria. So on these lines only you remember that we are fair to both psoriasis, lichen planus. To psoriasis we give two things, hyper and para. To lichen planus, we give it only hyper, so we had to give it hypergranulosis. Means psoriasis should not have thickening of granular layer. So much so that psoriasis actually has no granular layer. So you'll remember psoriasis is agranulosis. Why? Because uska two things are already done. It got two things, right? So that's why psoriasis agranulosis. So that's how you can remember. Then we have spongiosis. Spongiosis is intercellular edema. So edema between the different cells is called as sponge. Sponge absorbs water, right? So this is intercellular edema, which is seen in acute eczema. The only important part here is don't mix it with intracellular edema. Where did we discuss that? So intracellular edema is called as ballooning of cells, which was seen in herpes, right? So that's HSV. So intereczema. Acanthosis, as the name suggests, is thickening, right? So this is thickening of the spinous layer. Again, psoriasis. We did not give it granular, so we had to give it acanthosis. Acantholysis, we already have done. Let's revise. Pemphigus because there are anti-desmoglein antibody, staphylococcal scalded because that's cousin of pemphigus. Then we saw herpes, and what else? We saw diarrhea and Hailey-Hailey because you have calcium ATPase which is missing in these diseases, right? So that's how you derive this list through concept. Then let's do a cross mnemonic. What do we mean by cross mnemonic? When you see M, it's not M. M is what is seen in P and P is what is seen in M. So this is what is called a cross mnemonic. This is what we do when we have cross mnemonic, right? We'll study 7 to 8 throughout the BTR. So M is P, P is M. So Monroe's microabscess is what you see in psoriasis. These are neutrophilic collections. Okay, so these microabscesses contain neutrophil versus Potriers is what is seen in M for mycosis fungoides. So that is what is a cross mnemonic. M is P and P is M. What is mycosis fungoides? It's a cutaneous T-cell lymphoma. So this is where the microabscess actually has lymphocytes in it. So this is what is your cutaneous T-cell lymphoma. When this becomes, hematogenous, that's what is called as Sézary syndrome. And Sézary syndrome we learn as cerebriform nucleus. So that's where we learn cerebriform, right? Then Civate, C for C. First of all, this is a condition that's associated with Hep C. What is this? This is lichen planus. So Civate bodies are these apoptotic bodies that you see from the basal layer. So there in lichen planus, we see that the basal cell is degenerated and becomes apoptotic, and it's called as Civate bodies, right? And that is why the basal layer is empty, and that is what is called as the perfect Max Joseph space. I don't know why it's called perfect. Maybe Max Joseph named it itself, right? So this is Max Joseph ka perfect space, which is empty because basal cells are degenerated and they've become Civate bodies. On similar line, see how world is such a small place. C is C. Yeah. Now Hep C itself has these apoptotic bodies. You know what they are called? Councilman bodies. So you know two things. The common link being Hep C, both are apoptotic and everything starts with C. So can you correlate now? Councilman, Civate, Hep C. Yeah, so this is all about the dermatopath, and this is one pain point, right? This is where a lot of students make mistakes. So this is important for us, right? So now let's just see what we have, learned so far. Can you look at these images and tell me what we are looking at? I can see hyper, I can see nuclei in the stratum corneum. So I see hyperpara. The moment I see this, I know I am talking about psoriasis. Then what do I see? Monroe's microabscess, neutrophils, and ye kahan pe hai? This is in stratum corneum. So that means there must be some other pustules also. So those are called as Cohog's pustules, which are again neutrophils, which accumulate either in spinosum or granular, right? That reminds me of one more thing. What is Malpighian layer of skin? So Malpighian layer of skin is what is BS. What is BS? So that is basal plus spinosum, right? So just a one-liner, B and S is Malpighian layer. So this is spongiform pustule. So Cohog is niche, means down, whereas Monroe's is up in the cornea. Alright, then what do we have? Then look at this. You have thinning of suprapapillary plates, and this is actually the earliest finding. If they ask you, what is the first change? It's this thinning. And because this thinning of suprapapillary plates is happening, what happens is these dilated blood vessels would be seen. So the moment you scrape off the epidermis or the scales, what do we see? In psoriasis, we see bleeding spots. So we are going to talk about that grattage test. So these are the blood vessels, and you see these club-shaped reteriges. Reteriges means elongation of epidermis, whereas this is the papilla, right? Dermal papilla. So this is what are your findings of psoriasis. The pathophysiology of psoriasis, you can just, see this. You have TNF alpha upregulation, you have IL-6, C-reactive protein is elevated, and it's associated with HLA-B27 as well, seronegative spondyloarthropathy. Then you can see here, so this is what is lichen planus, right? So in lichen planus, can you see orthokeratosis? Yeah, hyper but not para. You can see hypergranulosis Wickham's tria. You can see the perfect Max Joseph space. Remember this empty space because basal cell degeneration has happened and they've become Civate bodies. And you see this inflammation, dermal inflammation, very important. So this is what is a T cell mediated. So you see the CD8 deposition, lymphocytic deposition, and this is also called as interface dermatitis, right? So this is also a potential question, never been asked. So this is about the dermatopath findings. Now we start off with skin lesions, right? So what are primary, what are secondary? So just to classify, they will ask you all are primary except. So you have macule and patch. Both of these are flat, all right? So they are divided on the basis of size. Some people also say 5 mm, more than 5, less than 5, but majority of the sources say 1, so we stick to 1. So macule is less than 1 centimeter, patch is more than 1. So these are both flat lesions, macule, patch. Papule and plaque. Papule and plaque are elevated, less than 1, more than 1, right? So that's papule and plaque. Nodule is similar but also has a depth component. So that's depth. So that's nodule. Tumor, very large mass. Then you have vesicle and bulla. Less than 1, more than 1. Filled with fluid. If that instead of fluid, that's pus, that's pustule. Then you have wheal, very important. So wheal is what is dermal edema. It's a primary lesion, right? So that's dermal edema, hallmark of urticaria. So there's also PYQ. Annular lesions are seen in all except. So not in urticaria. You don't see annular lesions. I'm just going to write that. This is where you have completely written annular. So that is where you have completely raised lesions. So that's dermal edema. Apart from that, abscess is primary. Petechiae, purpura, ecchymosis. These are all, erythematous lesions that you see which needs to be distinguished from erythema, right? So what is the difference between erythema and purpura? This is what we can actually differentiate on diascopy. Diascopy means taking a slide and pressing on it. So actually what erythema represents is vasodilation. So if I take a slide and press on it, this is what is going to be blanched. But because in purpura we have RBC which has extravasated, will this blanch? No blanching. So this is also one thing, one utility of diascopy. Diascopy means take a slide and press on the lesion. Yeah, so petechiae, purpura, ecchymosis, depending on the size, are all primary. What is secondary skin lesions? Scale, which is thickened cornea, particularly seen in psoriasis. We will talk about that. Lichenification, very important, seen in chronic eczema. Crusting, erosion and ulcer, and excoriation. So don't remember both, just remember the names of primary skin lesions. Very basic stuff. So now we talk about a few patterns of annular skin lesions. These are just spotters that, we need to identify and know a few terms. Just because they're confusing, I've, just brought them all together. So first thing, when you see these nodular lesions on shin, look at these two images. Both are nodular lesions in the shin, right? This one is on the anterior shin, whereas this is on the posterior shin. Let's talk about this one first. What is this? This is erythema nodosum. Everywhere E is going to be erythema, so I'll just write E. Erythema nodosum. Associated with histoplasma TB. Very important, sarcoid. So sarcoid, where you have EN, erythema nodosum, this is called as Lofgren syndrome. As the name suggests, EN for erythema nodosum, L for hilar lymph node. So hilar lymph node plus EN is Lofgren, subtype of sarcoid. Also seen in Behçet's disease, autoimmune. Also seen in inflammatory bowel disease like UC and Crohn's. Also seen in IBD is this. So this is pyoderma gangrenosum, right? So this is also a finding which is seen in IBD. So two things in IBD, EN, erythema nodosum, which is actually more in Crohn's more than UC, whereas pyoderma gangrenosum is more in UC compared to Crohn's, right? So this is about EN. Now what is this which is present on the posterior shin? The other difference is this can undergo scarring. This can undergo induration. So what is this? So this is erythema induratum of Bazin. Scary name, just remember Bazin. Okay, I remember this as Bazigar. Okay, so this is erythema induratum of Bazin. And if somebody will ask you which disease is Bazigar, always TB, right? So this is what is erythema induratum of Bazin, which is associated with TB. It's a tuberculide. Tuberculide means it's not TB infection. It's a hypersensitivity because of TB. So if you do a biopsy, will you see TB? No, it's a hypersensitivity reaction, right? So just remember posterior shin, induratum, Bazin, Bazigar, TB, right? So these are two shin lesions. Then look at this. What is this transient erythematous lesion? This is erythema marginatum, right? So you can see the name. It has AR. It is seen with acute rheumatic fever. Major criteria, Jones. We will study this in CVS. Marginatum, transient itchy lesions. Then look at this target lesion right here. So this is what is a true target. In fact, both of these are true target lesions. The first one where you see, associations with some infections or drugs, this is erythema multiforme, right? So this is multiforme. This is associated with herpes mycoplasma, associated with sulfa drugs, beta-lactams, chloroquine. Chloroquine is a PYQ. Now, easy to remember because chloroquine produces target in the hand also, target in the eye also. What is this? This is bull's eye maculopathy. In fact, chloroquine produces eye changes in every layer. It produces cornea verticillata. It produces anterior subcapsular cataract and it goes into fundus and does bullseye. So that's another ophthal correlation कि हर layer पे chloroquine does something. Cornea verticillata, anterior subcapsular cataract and bullseye. So bullseye के ही दो integration हो गए. One is multiforme, one is bullseye, right? So this is erythema multiforme. Another true target lesion, this is erythema migrans. This is associated with Lyme. We've studied this in micro, right? Exodus, hardtick, Borrelia burgdorferi. So we have learned that. History of trach would be given. So to mark this, you will think of history of trach, tick bite, trach, tick. Then here, these are two extra edge things. Here they will tell you that there was, contact with some hot object. For example, let's say you put your laptop on your abdomen or you put this hot heating bag constantly on your abdomen. The skin lesion is called as erythema ab ignis. Ignis matlab fire. Yeah, so erythema ab ignis, hot object. Putting laptop on your thigh and studying. Erythema ab ignis. So don't do that. Then this is what is very like designer erythema. So this is erythema gyratum repens. So this is erythema gyratum repens. It is a paraneoplastic syndrome. And any ajib, A for ajib, weird paraneoplastic syndrome is always ajib meaning adenosine, right? So these are few erythema lesions all together. Okay. Then let's talk about papillosquamous. So papillosquamous disorders will study around 5-6 diseases, the prototype of which is psoriasis. So this page, these three, all of these come under papillosquamous disorder. So the prototype, the most important disease that we are now going to talk about is psoriasis. Right? So now let's talk about psoriasis. How is the prototype lesion? So this is where you see three buzzwords. Erythematous lesions that you can see on the extensor surfaces associated with silvery scales. So extensor, silvery scales, erythematous lesion is prototype psoriasis. But can it be seen on the flexural surfaces? Yes. So usko kya bolenge? What will we call that? We will call that inverse psoriasis. So if you see it on flexural surfaces, on the chest wall near the folds, that is inverse psoriasis. So that's done. Then psoriasis is a condition that also affects the nails and the joints. So this is where you see these typical nail findings. What are you seeing here? Can you see pitting? Which pitting? irregular pitting. So this is where you are gonna see irregular nail pitting. Where do we see regular? That's alopecia areata, right? So we see irregular nail pitting. What else? We see oil droplet changes, and that is what is the pathognomic finding, hallmark. So oil droplet changes, yellowish nails that you can see. You can also see subungual hyperkeratosis. So that's another finding, subungual hyperkeratosis. All right, so these are nail changes. You can also see joint psoriatic arthritis, very important. What is the hallmark? You will see this gross destruction. Can you see how there is complete destruction of the phalanges? And what is this appearance called? This is what is called as telescoping or pencil in cup. So this is what is called as pencil in cup or telescoping of the joint. Sometimes the joints may be so severely damaged, it's also called as arthritis mutilans. So these are a few buzzwords for psoriatic arthritis. The most common joint involved is DIP. In this also you can see that DIP is most commonly affected. And the most common pattern is oligoarthritic pattern, meaning less than or equal to 5 joints affected. So that's oligoarthritic. So that's psoriatic arthritis for you. Then let's look at a few tests. These two. What is this test? So we take a slide, we scrape off the scales. You saw the blood vessels which were there in the dermis, right? So they start to become prominent. So this is what is called as the Auspitz sign, where you see these pinpoint patike, and this test is called as grattage test. So as you keep scraping off, you see a membrane that's called Berkeley membrane. And as you keep scraping further, you are going to see Auspitz sign, which are these pinpoint patike, right? So this is what you see here. If you want to remember one more, fancy word here, you can remember Voronoff's ring. So Voronoff's ring is typically a halo that we see because of prostaglandin release. This happens post-treatment actually. Not very important, but just know these fancy names are all associated with psoriasis. Then if you take a lesion and you extend it, it will get extended. And what is this called? This is what is very, very important, called as Koebnerization. Koebner's phenomenon, also called as isomorphic phenomena. So Koebner's or isomorphic is what is seen in 3 conditions actually. Remember LPV. What is LPV? Lichen planus, psoriasis and vitiligo. So lichen planus, psoriasis, vitiligo show isomorphic, they will extend. The fourth option only you can remember, which they will give you, that is warts. So that is what is called as pseudo Koebnerization. So pseudo Koebnerization is what we are going to see in viral warts, and that's not really extending, it's infection which is extending. So that is auto inoculation. So that is pseudo Koebnerization. In addition, there's reverse Koebnerization also, which is healing on this trauma. So that is also seen in psoriasis. So reverse is also seen in psoriasis. So remember LPV, not warts, right? Then 3 modifications of psoriasis. This one. This is the only one that's associated with infection. So in children, they will tell you it follows URTI associated with strep pyogenes, right? Group A strep. And this is looking like raindrops. Raindrops matlab guttate. So this is guttate psoriasis. Because this is linked with infection, what would be the treatment? Antibiotics. The only psoriasis that can be treated through antibiotics like macrolides. So that's guttate psoriasis. Look at this, such thick shell of, scales. So when you see thick scales, this is a variant. This is called as rupioid psoriasis. So you can remember Rupa. Rupa has a lot of scales, or she lives in a shell. So Rupa, shells. Okay, so that's rupioid. Now, we never use steroids in psoriasis, oral steroids in psoriasis, because when you withdraw steroids, a dangerous subtype will come, which is pustular psoriasis. So pustular psoriasis is what is associated with withdrawal of steroids, and that is why they can ask you everything is used in treatment of psoriasis except, and your answer is systemic steroids. Very important. So this is because of withdrawal of steroids, right? So now let's do the treatment. Before that, some more pathophysiology. As we discussed, two HLAs, B27 you already know, HLA CW6. The cytokines are TNF alpha, IL-17, IL-23. That also explains how we will treat. When we use biologicals or new drugs, we are going to block all of these. So that's what we are about to study. Just a one-liner, what conditions can worsen psoriasis? So lithium can worsen any skin condition. So that's common. Chloroquine does everything. Beta blockers. This is something that can be asked. NSAIDs, steroids, alcohol, smoking. Steroids also, now you know, it leads to pustula. So that's why we don't use steroids, right? Alcohol and smoking anyways worsen everything. NSAIDs also worsen everything. So everything is logical. The only question worth asking is beta blockers, and they've asked it just last year, right? Now let's go to the treatment. So if you have very small patches of psoriasis, all you can do is give topical steroids. Yeah, so topical, not systemic. Topical de sakte hain. We can give topical. But if it is more than 10%, now my first line is phototherapy. Phototherapy means to give PUVA. PUVA means sorrelin, which sensitizes the skin to UV radiation. You can say it's opposite of sunscreen, right? So sunscreen protects us from UVA radiation. This makes it more sensitive. So you give sorrelin and then you give UVA so that, you know, the skin gets damaged. Here I want the skin to be damaged. And you can also use narrow band UVB radiation. This is 311 nanometer. I don't know why I remember this. So this is UVB. So this is phototherapy. If this is not responding, now we start the drug. So we can give methotrexate, the drug of choice for arthritis. Erythroderma means 90% body surface involved. Directly start methotrexate. So the drug of choice, methotrexate. Treatment of choice for more than 10, phototherapy, right? So if you have joint, you have 90%, you directly start methotrexate. Pustular psoriasis. Pustular psoriasis is its special type, deserves a special treatment. That special treatment is acitretin. Acitretin, as the name suggests, is a vitamin A analog. Every vitamin A analog, you know, is teratogenic. This is so teratogenic. For 3 years, a woman is advised to avoid pregnancy if they have taken acitretin. So acitretin ka washout period is 3 years, right? You'll remember that. You can also correlate this with isotretinoic acid, which we are going to study towards the latter half of this video. For nodulocystic acne, uska washout period is 3 months, right? So 3 years, 3 months, both vitamin A analogs, right? Then impetigo herpetiformis is actually a gross misnomer. It is not impetigo. It's not a skin infection. It's not herpes. So they just named it. You know what it is? It is pustular psoriasis in pregnancy. So this is impetigo herpetiformis, the treatment of choice. Now, can I use acitretin? Obviously not. You're not allowing one to get pregnant for 3 years. Can I use methotrexate? No, contraindicated. Can I use radiation? No. So what is the only thing remaining? So this is the only condition where I can use systemic steroids. So the only condition where we use steroids is pustular psoriasis in pregnancy. Von Zumbusch disease, again, just know the name is just diffuse pustular psoriasis, right? So pustular psoriasis throughout the body called Von Zumbusch disease, just name, fancy. Then let's do the new drugs, right? So newer biological agents. So I7, naam mein hai, it's in the name, IL-17, 1N. Here you can remember Ria ke gaal pe til. That's a mnemonic, so you can remember that. So Riza, gal. Gal means cheek, til. Til means mole, skin, derma. So Ria ke gal pe til. What is this? This is 2 to 3 ducts. So this is IL-23. 2 to 3 til, you can remember. So IL-23 inhibitor. This is Ustad drug. Ustad drugs means blocks a bunch of stuff. So 12 also and 23 also. So this way only you can know that these are the 3 cytokines which are involved in psoriasis. Then you have 2 new drugs. This is Apremilast, this is a PDE4 inhibitor, new drug. Tofacitinib, will also study this in rheumatoid arthritis. So this is what is a JAK kinase inhibitor, JAK1 and 3 inhibitor. So these are all the new drugs. You can also use TNF alpha inhibitors because that also has a role, same as rheumatoid, right? So this is what are a few drugs which are in psoriasis. Now just spotters for other papillosquamous disorders. Look at this. This is what we learn as 6 P's, right? Not important now. Done? You have passed your undergrad dermat posting. Don't need to remember now. Pruritic, purple, planar, polygonal, papule plaque. Not important. So this is what is lichen planus. You know, out of the 6 P's, what is important is a W. So what is the hallmark is the Wickham's stria. And what did we learn? What is the histopathological counterpart? It's thick granular layer. So the histological counterpart here is hypergranulosis, right? This is lichen planus. It tends to affect the flexural surfaces unlike psoriasis, and this is associated with hepatitis C, Civate bodies. Nail changes here. This is called the elevated nail plate called as pup tenting or pterygium. So this is what is a pterygium formation. In addition, you may also see these lacy oral mucosal lesions. So this is what are these lacy reticular oral lesions. Can it be wiped off? Nothing can be wiped off except candida. So in micro we will learn nothing can be wiped off. When I ask you anything, can this be wiped off? Can diphtheria membrane be wiped off? No. Only thing that can be wiped off, candida, right? So this cannot be wiped off. In addition, it affects hair. We will study it causes alopecia. In fact, it causes scarring alopecia, right? So that is all the findings of lichen planus. Also has triggers which you can remember as ABCD. This has also been asked. ACE inhibitor, see, beta blocker comes here. Chloroquine comes literally everywhere. And this I feel, you know, is a very askable question, dental amalgam. So the only takeaway is ACE inhibitor and dental. B and C we know from psoriasis. The treatment is topical steroids. When you have a doubt, you say topical steroids. Or if it's fungal, you say topical azoles. If you have more doubt, you combine them in a cream and give to the patient. Your patient will be healed, right? So that's derma treatment for you. Either azoles or steroids. So here it's not fungal, so steroids. Then you have this nodular tiny lesions. This is called as lichen nitidus, PYQ, image based question. And this histopath appearance is looking like somebody is trying to catch a ball. So somebody's claw trying to catch a ball. Claw catching a ball. That's the legit histopath term they've given. Okay, so that's lichen nitidus. Then look at this also, PYQ. This is PRP. Everything is in the name. This is pityriasis. Pityriasis meaning papillosquamous. Rubra. Rubra means red. So you can see red. Pilaris means hair. So red lesions which are papillosquamous around the hair follicle. Perifollicular. So just the perfect name which tells you everything. This is also associated with palmoplantar keratoderma. You may also have thickening, right, of the palms. You may have checkerboard pattern on the skin, which is called as alternating ortho and parakeratosis. So hyper and para, hyper minus para. So hyper and para. So this could just have been alternating hyper and para. So this is what is checkerboard pattern. So these are buzzwords for PRP. Something that they love to ask is this disease. What is this? This is pityriasis rosea. What is pityriasis rosea? So this is what is associated with HHV 6 and 7. If asked to choose one, HHV 7. This is where it starts off with a herald patch, starting patch, one lesion, and that lesion has these scales. These have been asked. These are what are called as cigarette paper or a collarette of scales. So this is cigarette paper or collarette of scales, and eventually the lesion spread out in the trunk as a Christmas tree pattern. So that is Christmas tree pattern. So this is pityriasis rosea. Each and every fact here they have asked. The treatment here is conservative. What do you do for HHV? Nothing. You wait and watch. So this is pityriasis rosea. Then you need to remember this. This is pityriasis versicolor. Now this is actually a fungal infection. Can you see trunk or back of a patient showing hypo and hyperpigmented areas? So first of all, you see hypopigmentation as well, hyperpigmentation as well, usually in the photo exposed area, meaning sun exposed areas, right? Hypopigmentation happens because the fungus that causes this makes azelaic acid. It's also something you would have seen in skin ointments, right? For acne scars, if you want to remove the scars, you can try azelaic acid ointment. So this is what decreases the pigmentation. Whereas hyperpigmentation is because of more melanosomes in certain areas. So that is why versicolor, multicolor, right? The fungus that we are talking about is Malassezia, right? Traditionally, we always thought Malassezia furfur, but actually Malassezia globosa is more common than Malassezia furfur. Furfur has F, na, so it got famous. But actually more common cause Malassezia globosa. Because it's a fungus, we will see it on KOH, right? So you can see the KOH mount whenever you suspect a fungal infection. Tinea versicolor hai, you will always do KOH and you'll see these hyphae here. And this is what has been described as spaghetti and meatball appearance, because you can see lines, spaghetti, you can see meatballs. So that's spaghetti meatball. And for all fungi, you can culture it on SDA. Because this particular fungus is lipophilic, I also add some olive oil. What happens when you want to make a fried egg? Would you put oil in it? Always. So that is why this is called as fried egg, because you put olive oil. So this looks like fried egg. This is fried egg appearance, one of many we will learn as we go along. So this is P versicolor. Wood's lamp is important. This makes golden yellow color. And you see Brani scale. So that completes 3 scales. That's a previous year question of match the following. Silvery scales, psoriasis. Colorate or cigarette paper, P. rosea. And Brani, P. versicolor, right? So that was match the following. There was fourth. The rule of match the following is learn any 3. So you'll be able to answer the question. What is Wood's lamp? So Wood's lamp is UVA radiation of 365 nanometer, which passes through this filter, that is barium and nickel oxide. How you can remember is banya. So you can remember once a banya, always a banya, 365 days. So this is BANA 365. Alright, so this is about P versicolor. Then you can see a black lesion in the palm. Black matlab negro, nigra. So this is tinea nigra. We will learn that nigra kabhi bhi black hai. You will read the word hote. You will also do that in piedra, stones in the hair. Piedra means stones. So black piedra would be hote, right? So this will study in micro. So this is one more black, true black lesion, right? You remember black fungus? A lot of people started calling mucor black fungus after the pandemic. But this is what is the true black fungus. So that's why they asked this, that who is true black fungus? So that is nigra horte vernicae. Horte matlab black. So this is all about the papillosquamous disorders. So now let's talk about the infection. So here we're going to talk about bacterial skin infections. Very easy, very high yield, okay? This is the first one where the buzzword is going to be honey crusted lesions in a child, okay? So honey crusted looks like that also, right? So honey crusting is what is seen in impetigo. So this is what is impetigo. It's a bacterial infection of the superficial skin. This is where the epidermis is essentially affected, and the causes would be strep and staph both, right? So both strep and staph. When I say strep here, I mean group A strep, strep pyogenes, right? So this is impetigo. So group A strep S. pyogenes. This is where group A strep, can infect the skin. That's the entry point, either skin or sore throat pharyngitis. And that molecular mimicry is what may result in either acute rheumatic fever or PSGN, post-streptococcal glomerulonephritis, right? So they may give you history of impetigo, and then it can go to the heart, acute rheumatic fever, go to the kidney leading to hematuria, PSGN. So this is impetigo. On the other hand, when this is fluid filled, this is what is called as bullous impetigo. So bullous impetigo is not strep and staph, it's only staph. Why only staph? Because only staph can produce exfoliative toxin. It is this exfoliative toxin which results in bullae formation. Now let's delve deeper into this. This exfoliative toxin, you know what it does? Why does it make bullae, which we see in pemphigus? And now can you correlate this to acantholytic cells that we read? So this is what attacks desmoglein 1. So superficial desmoglein is attacked. So desmoglein 1 upper, desmoglein 3 niche, it's below. So desmoglein 1 is attacked, because of which you have bulla formation, and this is why if it becomes severe, this is called as staphylococcal scalded skin syndrome, where they will give you history of a child, particularly an infant, who has diffuse peeling of the skin, and diffuse peeling is happening because the superficial desmoglein is attacked by the exfoliative toxin. So this is also called as Ritter's disease. Desmoglein 1 not present in oral mucosa, so no oral mucosal involvement. So this is what helps us distinguish it from pemphigus vulgaris. Vulgaris in derma matlab not vulgar, most common. Okay, so P vulgaris is desmoglein 3, little deeper, affects the mucosa, not desmoglein 1. Right? Now, another tangent is Ritter's versus Ritter's. This is Ritter's. Ritter's disease is a triad. Triad of can't see, can't pee, can't climb a tree. Can't see, Q, because of conjunctivitis. Can't climb a tree because of arthritis. And can't pee because of urethritis. So urethritis, conjunctivitis, arthritis, this is also seronegative spondyloarthropathy. This is also something that can cause sacroiliitis, right? So this is also like psoriasis and Ritter's, all of these, angspond, all of these are seronegative spondyloarthropathies. So that's Ritter's, and here you will have history of, either an STD or a GI disease, past history of STD or GI. Frequent culprit is Campylobacter, could be Shigella also, but Campylobacter is most commonly asked. Two associated derma lesions in Ritter's would be this. So the glans penis is affected. So this is what is Circinate balanitis. Circinate mane serpiginous lesions, and this is Keratoderma blenoragicum. Right? So this is where the palms and soles are affected, like PRP. Pityriasis rubra pilaris, palmoplantar. This is also palmoplantar. So this is Keratoderma blenoragicum. So this is Ritter's disease, right? Then going back, now the infection is deeper. Impetigo was epidermal. Now this is dermal. So this is the first one, that is erysipelas. Erysipelas is superficial dermis, right? The spelling is wrong, but that's okay. Erysipelas, no, it's not a spelling test. So this is erysipelas, superficial dermis, whereas if that goes deeper, that becomes cellulitis, deep dermis. All right, so erysipelas is caused more by strep. So if asked to choose, you will say strep. All right. Some sources also say staph and both, but from most of the sources it's strep, and that's what we stick to, and that's fair also, right? Bullous impetigo was only staph, so I have to give justice to strep. So this is only strep. So that's erysipelas. Very important. The margins, can you see how well defined they are? So very well defined margins, raised margins. This is what we see in erysipelas, and there is something called as a million ear sign. What is million ear sign? They say that if the pinna is affected, it is very, very typical for erysipelas, right? Because there is no deep dermis in the pinna. All right. So that's erysipelas, cellulitis, deep dermis. This could be strep and staph, both. So now visualize this page. Impetigo, cellulitis, extremes, both. Bullous impetigo, only staph, erysipelas, only strep. right? So that's how you do active recall. You see this page, you should hallucinate all four images and revise. All right, so this is done. Then let's do these hair follicle based three lesions. The first one is simple. Folliculitis happens in men more commonly, shaving with old razors, etc. Follicular inflammation, folliculitis. If there is an abscess around the hair follicle, for this is furuncle. All right, so this is what is furuncle, abscess around hair follicle. If you have multiple such abscesses discharging sinus, this is carbuncle. Carbuncle, diabetic uncle. So this is what is seen more common in diabetics. So you can see diabetics take more carbs, so carbuncle, right? But don't mix this with another neck in diabetics. All right, somehow diabetes and neck don't go well together, but this is super important. This is scleroderma. This is not scleroderma. The most common question here is to confuse you with scleroderma. Scleroderma, you know, is thickening of the skin, fibrosis of the skin. Morphia is localized scleroderma. This is scleroderma diabeticorum, seen in diabetic patients. There is thickening of the skin, but in this case, there is mucin deposition, right? So this is what is seen in diabetic patients, scleroderma. The only thing you remember, not scleroderma, right? So this is about the abscesses around hair follicles. Then if we go deeper into dermis and into the hypodermis, this is necrotizing fasciitis. You can see how severe it is. This is typically polymicrobial, and if this involves the groin, this is what is called as Fournier's gangrene. All right, so Fournier's gangrene is nothing but necrotizing fasciitis of the groin. So this is polymicrobial, particularly this is a PYQ on Fournier's. Is the testis involved? No, it's a skin infection, right? Why would testis be involved? So the statement there was, is orchidectomy needed? No, why would orchidectomy be needed? All right, so not needed. If they ask you drugs, remember glyphosins, SGLT2 inhibitors, you know, they cause candidiasis, they cause UTI, because you are allowing glucose to come into the urine, and glucose wherever it goes is a bed of infection. So this is why it can also lead to Fournier's. That's a question which has not been asked so far, right? So that's Fournier's. If you have an infection of the abdominal wound, this is what is called as Melanese gangrene. So this is Melanese gangrene, where you have a burrowing infection, orange infection. All right, so these are all again names. Let's go into the axillary pattern now. So in this slide, you see 5 axillary pattern. First one, infection. Which infection? Red hai. Red matlab erythrasma. So this is erythrasma. Even on Wood's lamp, this is red. So it makes this coral red fluorescence on Wood's lamp. Very commonly asked question. So this is erythrasma. Which other color did we do? Yellow. So that was T versicolor. This is second one, red. Erythrasma is caused by Corynebacterium minutissimum, also called as Corynebacterium, not diphtheria, by me, right? So just remember it's not diphtheria. Let them remember minutissimum. So this is what is erythrasma. It makes protoporphyrins actually. This Corynebacterium makes protoporphyrins. That's why it looks red on Wood's lamp. Another red axilla here. So this is where they will describe the area to be very hot and humid. They will describe satellite lesions. So there are satellite lesions, affects folds, intertriginous areas, either axilla or groin folds. What are we talking about? We're talking about candida, candidal intertrigo, right? Intertriginous areas between folds, right? Apocrine sweat glands, axilla, right? So जहाँ जहाँ apocrine glands है वहाँ वहाँ candida है. Wherever there is apocrine sweat gland, there is candida, right? So this is what is candida. We will talk further about this. Black velvetish lesion is the buzzword here. Black velvetish lesions. What are we talking about? We are talking about acanthosis nigricans. Wherever there is black, you will see they have not left any chance for racism. The name will have nigricans. So this is acanthosis nigricans. Associations. This is associated with insulin resistance. So association with diabetes, association with PCOD, right? It is also associated with neoplastic syndromes. And again, who does achieve paraneoplastic syndromes? Adenocia, right? So always adenocia. So this is what is acanthosis nigricans. This is also called as hair and syndrome, which is nothing but hyperandrogenism, which is hirsutism, insulin resistance, and acanthosis nigricans. So everything that we've studied. There is also Saha syndrome, same, seborrhea, acne, hirsutism, alopecia. These are all symptoms that happen where you have hyperandrogenism. So seborrhea, acne, hirsutism, alopecia, right? So Saha, hair and acanthosis nigricans. Then look at these two. So remember we were talking about Darrier and Haley for acantholytic cells. They were also forming the communications. So this is where in both of these we have a defect, a common defect of calcium ATPase. Alright. So in both of these calcium ATPase is defective. The first one where you see these neck lesions, these are called as crop grains or crop ronds. Alright. These small lesions in the neck. This is Darrier's disease. Whereas when you see the axilla, again axilla which is red, this is what is Haley. So now you remember Haley's comet. So Haley's comet. So you'll remember Darrier's is 2A2, Haley's comet is 2C1. So calcium ATP is 2C1, 2A2. Don't remember completely, just remember Haley's comet. कि यहाँ C है, यहाँ पे A है. Alright, so this is the defect and this is where we had learned acantholytic cells. Now look at the associated findings. In Darrier's, you see this V-shaped split in the nails. In Haley, you see these longitudinal lines. And comet, when it hits the house, what will it do? It will break the house. So this is where you see this dilapidated brick wall appearance. So you are going to see this destroyed appearance. Can you see fluid clefts within? So that's nothing but the acantholysis that's happening. So this is dilapidated brick wall. So these are your two calcium ATPase defects. We were talking about candida and intertrigo, right? So now let's see perianal involvement like that. So this is also another skin fold just like axilla. So in a child, this is what has been unexplored in NEET PG completely. Very common question in USMLE. So I thought this can be asked. So this is where you have 3 DDs for a child with a diaper rash. It could just be what is an uninfected diaper rash, that's contact dermatitis. Because the children will wear diaper, they'll pass urine, fecal matter, stay in contact, that can result in contact dermatitis. The hallmark is this pairs the skin folds. Like you can see here, the skin folds are not involved and the treatment is just use a diaper rash cream, give diaper free time, the child will respond very quickly. So spare skin folds. Candida will affect the skin folds. So uska hallmark hai that only the skin folds are affected. The other hallmark, beefy red satellite, same as axilla. You can use topical antifungals. And third is streptococcus. This happens in older kids. This is where there will be very sharp erythema. So this is very similar to, either erysipelas or impetigo. So this is what is happening in little older kids, same age group as impetigo, oral antibiotics. So this is where the 3 buzzwords would be spare skin folds, affect skin folds, older kids with well demarcated red patches. So this is about extra topic perianal dermatosis. Now let's talk about parasitic infections of the skin, right? A very high table. Predominantly I need to teach you scabies. So Sacroptus scabi is what is a mite. They have also asked you how many legs this mite has. So this mite, first of all, it takes around 10 mites to cause scabies. Then what you can see here is it has 2 pairs of anterior and posterior legs if you want to know so much detail of this. So it has 2 pairs of anterior and posterior legs. How it affects? So it causes burrows. So they will show you the web spaces. In the web spaces, they will say that these mites, look at these mites, they are digging these burrows. They live in the stratum corneum and they lay their babies here. So this is burrows. So the hallmark are these burrows in the digital interdigital web spaces. So that's the hallmark. Too much pruritus more in the night, right? And this affects the interdigital spaces, wrist, waist. This complete thing is called as circle of Hebra. That's not very, very important, but that is what it affects. And important is face is spared in adults because we have sebum. That's what causes acne. So हमें acne होता है तो scabies नहीं होता. Children don't get acne, so they get scabies because their skin on the face does not have a lot of sebum. So face is spared in adults. The buzzword here is the treatment. Very, very important. So you know the drug of choice is 5% permethrin. So you will do topical application. Apart from that, you clean all the clothes, bed sheet, etc. So 5% permethrin below the face you have to apply in the night and sleep on it. So they had asked last year that what is contraindicated in infants pregnancy, or in other words, what is safe in infants and pregnant females. So sulfur is safe, sir, and permethrin is safe. All right, so sulfur and permethrin are safe in infants and pregnant female. They can also ask you what is contraindicated. So everything else. So one is benzyl benzoate can be used, but not in pregnancy. Then ivermectin can be used. Particularly ivermectin has a role in Norwegian scabies, right? So Norwegian scabies is what happens in immunocompromised patients, but do not use it in pregnant and infants. And you have lindane, which also has a role. So total of 5 drugs have a role in scabies, out of which sulfur and permethrin can be used, but the other 3 are contraindicated. All right, so that's about the treatment where you get questions. Then you have leishmania or oriental sore. So this is what is your phlebotomous sandfly, right? So this is what is causing, Delhi boil is one more name, Delhi boil, oriental sore. So this is leishmaniasis, where you have an ulcer with raised edges, and I'll teach you this is also called as, volcano sign, because there's central crusting which can be seen. So that's what this looks like. Then look at this creeping pattern, very commonly asked. This is cutaneous larva migrans. This happens because of animal hookworms. So animal hookworm, Ankylostoma brasiliensis, is the most common cause. That's a PYQ, right? And these creeping eruptions progress at 1 to 2 centimeter per day. But if it progresses faster, 5 to 15, we call it larva currents, and that is strongyloides. So in micro, we have studied that there are only 3 infections which penetrate through the skin: strongyloides, hookworm, and schistosoma. But schistosoma does not cause skin infections, right? So they all come through the skin, but only 2 cause skin manifestations. So cutaneous larva migrans, a movement, creeping movement, that's ankylostoma or animal hookworm, or you have strongyloides where it travels faster, called as larva currents. Do not mix that up with visceral larva migrans. So this is where you have these serpiginous lesions now in the liver, most commonly viscera, and this is what is caused by Toxocara, again animal parasite, Toxocara canis or catus, right? So this is CLM VLM, micro topic but pretty important. This also we've studied in micro. Onco 0, you remember, river blindness. So this is where river blindness, black dikhega. So this is where you will see this leopard skin appearance, all right? And this is what is onchocerca. Loa loa can show you calabar swelling. So you may just see the worm also moving around in the eye. So that's loa loa. We have discussed this in filaria. Demodex can cause this rosacea-like skin infection, papules, and this is also because of mites, just like scabies, and pediculosis. So pediculosis, very important, can affect the body. So pediculosis corporis or capitis, which affects the scalp, very common in children. We know children get lice. So this is what is a louse. So this is pediculosis, and you have pediculosis pubis, on the other hand, is a pubic infection acquired sexually, and this is just one unique thing that you may see a blue patch. Macula means macule, ceruleus, ceruloderma means blue, right? So bluish macule can be seen in the abdomen, but it's not corporis, right? It's actually pubis. So this is what is macula cerulea. So these are few extra edge. All of this page is little extra edge except for scabies, right? So these are parasitic infections. So now we start with leprosy, super important. So I've compiled everything you need to know about leprosy right here. So the PSM aspect and the derma aspect. So leprosy, you know, is caused by a mycobacterium, acid fast bacillus, mycobacterium leprae, right? So now what you need to remember in leprosy is the Ridley-Joplin classification. So according to Ridley-Joplin, there are 5 types. It's actually a pole, right? So one pole is called as the tuberculoid pole, and this pole essentially represents the area where our cell mediated immunity is very good. So tuberculoid, just having TB, why it's called tuberculoid, just having TB, your immunity is good and you have granulomas, that's the type that is TT. But if your immunity is weak, you don't have T cell immunity, now what will the body do? The body will rely on humoral immunity, antibodies. So that's the lepromatous pole. So this is where we go from a good immunity to a weak immunity. So tuberculoid, borderline tuberculoid, borderline lepromatous, and lepromatous. So that's the spectrum. You can understand it very, very conceptually. So here, because the immunity is good, the number of lesions will be low and it keeps increasing as you go to lepromatous. From one well-defined lesion which is elevated margins, it becomes ill-defined. From a single nerve that is thickened, you have more nerves. From slit smear negative, it becomes positive. So this is important because here, you know, your immunity is not there. You will find the acid fast bacilli in the lepromatous pole, not in the tuberculoid pole. Here the lesions have loss of sensation, but here they have sensation, but their complete nerves are affected, so much so that you have glove and stocking, you have polyneuropathy in the lepromatous pole. Very important. Because in tuberculoid pole our immunity is present, what will we see? We will see granulomas. So in the tuberculoid pole, you see granulomas involved, whereas because here there is no immunity, in lepromatous pole you see one empty zone, that's called Grenz zone, and you see these foamy macrophages, right? So foamy macrophages and Grenz zone are findings of lepromatous pole. Now we talk about lepromin. What students do is they mix this with slit smear. Opposite. What is lepromin? It's the counterpart of MON2, checking immunity. So can I say lepromin test is positive in tuberculoid pole and it is negative in lepromatous pole? Yeah. Apart from that, you will remember that TT pole is Th1 response, that is cell mediated. Th1 makes granulomas. Lepromatous pole is Th2. Th2 means IL4, IL5, IL13, humoral immunity, right? So that is what you remember, and the bacterial load you can see keeps increasing on this side of the spectrum. So this is a graph that is showing you the complete spectrum, right? So it's actually a graphical representation from TT to LL. Yeah, so this is something which is a new insight into how we can think of leprosy. Apart from that, this image has been asked, this is a PYQ. So this is the great auricular nerve. So, you know, leprosy likes colder temperature. So it will affect, you know, the ear lobule, it can affect the skin. So it affects cooler areas. So the great auricular nerve or superficial nerve can be thickened. Few buzzwords for you now. So there are two reactions. So in the lepromin reaction, now there are two phases. So Fernandez is what is the early reaction. This is what is positive at 48 hours, all right. So Fernandez के नाम में ही है ना early, ठीक है. So this is early at 48 hours, and this is what indicates a prior sensitization to the mycobacterium. You've been affected by it, just like TB, prior exposure. Mitsuda is what is the late reaction. This is what is read at 21 days, and this is what indicates a good cell mediated immunity which has developed over a long term. So Fernandez read at 48, early, prior sensitization. Mitsuda late means now you are developing immunity. So two phases of lepromin, never been asked, extra H. Then you have three forms, again extra H. So histoid form of leprosy is where you can see nodules, right? Then you have Lucio leprosy. So Lucio is a Mexican word. It's also called as bonito. Bonito or Lucio means beautiful. So this is where you have a very severe form of leprosy, that is lepromatous leprosy, and it is so diffuse and disseminated that your skin actually looks, more radiant. So this is where lepromatous leprosy has affected the face, and the face skin looks very, glowy. Then you have Lazarine. Lazarine is what is in malnourished, poor socioeconomic status. They have leprosy, and this is where the leprosy lesion become nodulo ulcerative. So these are just morphological, variants of leprosy. In addition, you also should know about the Indian subtype, right? So according to the Indian classification of leprosy, there are two more types. One is the indeterminate type. The indeterminate type, they say, has, good prognosis, and it can show spontaneous resolution also. And the other type is pure neuritic type. Because this only affects the nerves, this is where, we would want to do a biopsy from the nerves. So this is according to the Indian classification. According to Ridley Joplin, these are the 5 poles. So now let's look at the lesion morphology. So first of all, number of lesions will help you. So this is TT, this is BT, this is borderline, BL, lepromatous. So you can see the number keeps increasing. If you want to remember, TT is just 1, BT would be 1 to 3, this would be 3 to 10, this would be 10 to 30, this would be more than 30, right? So this is how the number of lesions keep on increasing. So now, when we talk about TT, usually a solitary lesion that is thin with well-defined margins. You will also see one nerve which is thickened, one lesion, and this lesion will have no hair, within it. So this is where this lesion will have no hair, sensory loss, demarcated lesions. BT hallmark is satellite lesions. So you can remember Santa Banta. Remember how we used to hear Santa Banta jokes? So satellite is BT. It's spreading. BB, very important, this borderline. So this is where you will hear words like geographical lesion, punched out lesions, annular lesions, right? You will hear the word inverted saucer. So this is where you have central clearing. If you don't know, you mark BB. So the idea is one lesion matlab TT, satellite matlab BT, everything else BB. BL, you see multiple lesions, and LL is there are so many lesions you can't even see them, so diffusely symmetrical, right? So this is how we identify. Few one-liners. The root of infection of leprosy is actually inhalation, not through touch, and that is why, in PSM we study Nikusht. So Nikusht bimari or Nikusht program is for the digital data of leprosy. There's also Sparsh program for leprosy, and the mascot here is Sapna, and we will look at Sapna when we go to PSM, right? So this is inhalation. Most common cranial nerve affected is 7th, but don't biopsy 7th nerve. What nerve will you biopsy? Are pure sensory nerve. So either you can biopsy the radial cutaneous nerve or the sural nerve, right? So radial cutaneous or sural. Earliest sensation lost is temperature, particularly cold temperature, and the stain is fight Furako stain. One more one-liner. Overall, most common peripheral nerve is ulnar nerve. So most common ulnar, most common cranial, 7th nerve. Fight Furako stain, particularly for Mycobacterium leprae. This is a PYQ. Criteria for prophylaxis. First of all, they are making us remember so much, for what? The prophylaxis is single dose rifampicin. It's the most effective drug against leprosy. Single dose is enough. Who to give this single dose? Anybody more than 2 years of age. You have spent more than 20 hours per week with the patient for more than 3 months. So much calculation for one drug. More than 20 hours in a week, 3 months. The impact indicator is any prevalence less than 1 in 10K, and this is why this is the definition of elimination of leprosy. We achieved elimination back in 2005. If the prevalence is less than 1 in 10,000, that's elimination. And another impact, this is also PYQ, is newly diagnosed cases with grade 2 disability, right? So this is about leprosy. Now going deep diving into PSM aspect. So we are now talking about the national leprosy eradication. We have already eliminated. So now we want to eradicate it. So this is the symbol. You have a lotus, you have sun, So this is what is the program. According to the program, now we want to divide into P and M, right? So we also needed mnemonics to remember BB, BT. How do you expect, grassroots workers to know? So that is why they've made the operational definition very simple. Tell if it's posse or if it's multi. How to know? So any skin lesion 0 to 5 is posse, more than 5 is multi. Any nerve involvement becomes multi. That's the recent update. Slit smear negative, slit smear positive becomes multi. According to the uniform MDT, now everybody gets the same multi-bacillary drug treatment. Possibacillary shall take it for 6 months, multibacillary will take it for 12 months. But everybody gets the same multi-drug therapy, which is this pack in adults. So previously we had 4 packs. Can I say now this is redundant? Nobody is taking posse. Everybody gets the same pack in adult and child. So adult का blister pack pink है, बच्चों का blister pack brown है. Could be उल्टा है ना कि बच्चों का pink होना चाहिए, but it's not like that. So remember, don't get confused. Pink is adult, brown is children. Now what you have to remember is RDC. What do we mean by RDC? So rifampicin is given as 600 mg once a month supervised, dapsone 100 mg OD. So clofazimine becomes half. So just remember these two. So this becomes 300 once a month, this becomes 50. So 600, 100 and then make it half for clofazimine. So this is RDC. Most effective bactericidal drug is rifampicin. Okay. Now, let's talk about lepra reactions. So, when we talk about lepra reactions, they are hypersensitivity. It's your body which is making these reactions. So, you have type 1 and you have type 2. Type 1 is a type 4 hypersensitivity, whereas type 2 is type 3 hypersensitivity reaction. Type 4 is cell-mediated immunity. So that is why this is seen more in the BB-BT spectrum where the immunity is good. But type 2 is what is seen in the LL pole where you have humoral immunity, Th2 response, and that's why you have more antibodies which results in immune complex. So what happens in type 1 reaction is as soon as you begin treatment, so this happens within 12 months of treatment. As soon as you begin treatment, your immunity improves, CMI improves and you have a reaction. So what happens is your pre-existing lesions become red. You don't have new lesions, pre-existing lesions, and there is no systemic involvement. But in type 2, you have lepromatous leprosy. There is no relation to treatment. You have such bad immunity, your Th2 is exaggerated, and because of that you are having new lesions. So 2 is new, and kaise new? What kind of new lesions? New nodular lesions. So this is called as erythema nodosum leprae. The patient will tell you that there are these new lesions which are happening now. So these are what happen along with systemic involvement like fever, arthralgia, you may have orchitis. So this is what is type 2. Very important, they'll ask you the management. Because these are hypersensitivity reactions, our body is doing them. What is very, very important? Do not stop MDT. These are hypersensitivity. They are not because of treatment. So very important, do not stop MDT. Now because type 1 is relatively mild, the first line is NSAIDs. But if it doesn't resolve, you go on to steroids. But in type 2, the drug of choice is steroids. Drug of choice and first line is steroids for type 2. Alright, you may also use thalidomide, that has also been described, but because of its teratogenic effects, phocomelia, we don't really prefer it. So this is about leprosy, super important. Now what we are about to start is the most important part of this video, which is sexually transmitted infections. We'll discuss the kits, and while learning the kits, we'll understand causes. So don't memorize, don't create mnemonics, we'll just understand. I guarantee you will remember. Okay, so when I say guarantee, when I say you will remember, no mnemonics, what do you say? You say great ma'am, wonderful. So kit 1 is great, so great that it treats 3 things: urethritis, cervicitis, painful scrotal swelling. So urethritis happens in males. Cervicitis, there they will give you that there are cervical erosions. On per speculum examination, if they give cervical erosions, you will give gray kit or painful scrotal swelling in males, right? So this is urethritis, cervicitis, painful scrotal grate. All three of these causes happen either because of chlamydia or gonorrhea, chlamydia being more common, but we have to treat for both. Now, you may do a gram staining. Gram staining will show you bacteria, gram negative diplococci in gonorrhea, whereas no bacteria in chlamydia. So that's one. The other investigation of choice for differentiating the two is NAT, nucleic acid amplification test. But we don't do that. Why don't we just treat both of them? We assume both are there and we treat them. So the drug of choice for chlamydia is azithromycin. The drug of choice for gonorrhea is cephalosporins. So that's what we do. We take azithral, 1 gram stat, and cefixime. Used to be 400 according to the update. Now everywhere we had cefixime, that has become 800. So 1 gram stat plus cefixime 800 mg stat. So that is why we are giving this in every patient. Just see the partner treatment for urethritis, scrotal swelling, treat all, and for cervicitis, treat when symptomatic. So this is about chlamydia, gonorrhea. Then let's talk about vaginal discharge. So green. You remember Rachel Green? Those of you who have seen Friends, you know Rachel Green. Imagine Rachel Green has vaginal discharge. I've completely ruined Friends for you. So green vaginal discharge. First you need to understand the causes and only then can we make the kit. So before we tell about vaginitis, we need to rule out physiological discharge. So when we talk about physiological vaginal discharge, the hallmark is there is no malodor, there is no itching, and this happens usually around mid-cycle during ovulation. So the hallmark is no malodor, no itching. If this is not physiological, three causes. Let's look at the buzzword. The first one, bacterial vaginosis. They will describe, as the name suggests, vaginosis, not itis. There are no signs of inflammation. So this is where they will describe off-white, fishy odor. The hallmark are these cells. What are these cells? Clue cells. So these are the epithelial cells which are coated by these bacteria. That is the clue cell. You will see a whiff test. If you put KOH, there will be this odor. So this is where we have the Amsel's criteria. It's essentially this. Now, vaginal pH is acidic, right? So the normal pH is 3.8 to 4.5. It is deranged in both. So you just remember that the pH is normal in Candida. Everywhere else, the pH is going to be more than 4.5. So that's how you remember pH. So Amsel's criteria, clue cell, whiff test. There is also a grading as per the number of bacteria, and that is called Nugent score. So all of these are buzzwords for bacterial vaginosis, which is caused by Gardnerella. So this is caused by Gardnerella vaginitis, all right, or vaginosis. The drug of choice, because it's an anaerobic infection, any anaerobic below the diaphragm, metrogyl, above the diaphragm, clindamycin. So you can use both. We prefer metrogyl. Second, trichomonas. So you remember trichomonas, auntie from micro. We will learn this in micro. This is where we have yellow-green inflammation, because of which the vagina or the cervix is called as strawberry cervix, because of the inflammation. This is where you do a wet mount and you will see the Trichomonas auntie. So this is where we have learned one eye, four anterior flagella, one posterior flagella. So this is what is the motile trichomonads that you can see. So these are the small trichomonads that you are seeing amidst the epithelial cells. Again, because it's inflammatory, it's anaerobic, we give metrogyl, and this is the only vaginal infection where we treat the partner. Remember that. Then you have Candida. Candida matlab C, cottage cheese, curdy discharge. Very important. You see pseudo hyphae, normal pH. Look at this. You can see the hyphae on which the epithelial cells are arranged, and this is what is called as the shish kebab effect, right? You see these hyphae on which, like a shish kebab, the cells are layered. Fungal hai, so we give azoles, fluconazole, right? So can I say I can just give azole and metrogyl and the problem is solved? Yes, but the thing is metrogyl is usually for 14 days. So that's why we can replace it with secnidazole. So the kit, the green kit is secnidazole 2 gram stat plus fluconazole 150 mg stat and treat partners when symptomatic, particularly in trichomonas. Only one more image which is here, so you can see how there are these, filamentous bacteria. So this is what is called as cotton ball appearance, cotton wool appearance associated with actinomyces, which is a gram-positive filamentous bacteria. And this is with history of IUD. If they give you history of IUD, somebody has PID, think of actinomyces, right? So this is what is your two spectrums here. So now let's talk about the kits involving genital ulcers. Okay, before we go into these kits, we need to learn the approach to genital ulcers. Super important. So here the classification for ulcers would be painful, painless. Anytime you get a question, and you will first start by saying that it's painful or it's painless, right? So let's say the ulcer is painful. Now the buzzwords that you have to read are, is it an ulcer or are these erosions, right? So if you see that there are these erosions, here the buzzwords they will use would be polycyclic, means multiple forms of erosions, and another buzzword would be erythematous base, right? So these would have a red base. So erosions, erythematous base. What will you think of? You will think of herpes. Which herpes? More commonly 2. So above the belt 1, below the belt 2. So HSV2, most common cause of these ulcers, which are painful erosions actually with an erythematous base. Then they can describe the Zang smear here. So this is Zang smear with what we have learned already, multinucleated giant cells, and they can describe here. So one is multinucleated giant cells and they can describe acantholytic cells, right? So this is what are your ballooning of cells, intracellular edema. So that's HSV. Then the other ulcer. So here they'll write a painful ulcer, sloping edges, sloughed base, so you can see the sloughy material coming out. So this is painful ulcer. This is what is chancroid. All right. So this is chancroid and this is what is painful. So your patient is going to cry. So this is Ducrey, Haemophilus Ducrey. The appearance here, so this is a Giemsa stain and this appearance is what is called as a school of fish appearance. So this is called as school of fish, and this is also one bacteria which can show you bipolar or safety pin staining. This is what it looks like, bipolar safety pin appearance, which we'll also study in a moment, but it can also be seen in H. Ducrey, right? So this is what is chancroid. Important that this is also where you may have unilateral painful lymph nodes, and that is why this is called as bubo. So this is one more cause of bubo. Typical bubo we will learn, but if they ask you can chancroid cause bubo, your answer is going to be yes, it can, right? So these are two painful things, erosions, HSV, ulcer, painful lymph nodes. This is going to be chancroid. Then we go into painless. If the ulcer is painless, look at the first one. This is what is called as a hard chancre. So hard chancre, this is syphilis. Painless, syphilis. That's how you will remember. So syphilis, hard indurated ulcer. Even the lymph nodes are going to be painless. It's described as shorty, painless, enlarged, shorty lymph nodes. So this is what is chancre. Syphilis, Treponema pallidum, we will learn about it in micro where we talk about dark field microscopy, right? So this is painless ulcer, syphilis. Then we talk about opposite of syphilis. It's painless, but everything else, it's not hard indurated, it's red and beefy. So when they describe this red and beefy painless ulcer, this is where we think of donovanosis. So this is donovanosis, also called as granuloma inguinale. So granuloma inguinale, as the name suggests, is caused by donovanosis bacteria or Klebsiella granulomatosis, and this is a bacteria that again shows us this bipolar staining or a safety pin appearance. So two things with bipolar on this page. Think of one painful, one painless. So you have chancroid and you have donovanosis, right? So that's what we need to know. And then this is very important. Here the ulcer, we are talking about approach to ulcer, right? So the ulcer is painless, not just painless, it's a transient ulcer. It is not even noticed. But what then develops is a bubo. So what you then see is this painful enlarged lymph node. So this is what we call as inguinal bubo. You see enlarged inguinal lymph nodes, and you can see the inguinal ligament as a depression in between. So this is what we call as the groove sign. So this is where you may see genital elephantiasis also as a complication, and that is where, you know, they may describe a few terms: genital elephantiasis. So this is where a few words like estheomine in the vulva or a saxophone penis may be described. So these are all, you know, complications because of the lymphatics getting involved. So this bubo is what is caused by chlamydia trachomatis, and that is LGV, which is lymphogranuloma venereum stain. Out of L1 to L3, it is L2 strain which is most common. So this is chlamydia trachomatis, and this is where you have a test called free test, free information. Okay. Apart from that, you see corpuscles here which are called as Miyagawa corpuscles, right? So they are what are the bodies which are seen in every chlamydia, you know, they are obligate intracellular. So that is why these corpuscles are seen. So this is what we have to remember. So now visualize this picture. Under painful, you have herpes and you have chancroid. Under painless, hard indurated is syphilis. Beefy red is going to be granuloma inguinale, and then you have lymph nodes. The ulcer was transient painless, but the lymph node has suppurated, and that is called as bubo, and that is caused by chlamydia LGV, L2 being most common. One more thing, in granuloma inguinale, you don't see lymph nodes. What you see are erosions, and they are called as pseudo bubo appearance. So pseudo bubo appearance are the erosions that happen along the lymphatics, right? So that is what we need to remember here. Just to club all the incubation periods, now both of these painful ones are having a short incubation period, 2 to 5 days. For syphilis, you will remember 9 to 90. For granuloma inguinale, 8 to 80. And for bubo, 3 to 30, right? So 9 to 90, 8 to 80, 3 to 30. That's what we have to remember, and out of everything they've asked 3 to 30 for bubo. Let's plan treatment. See, herpes is identified separately, treated separately using acyclovir. Bubo is a different syndrome altogether because it's presenting as bubo. We'll treat it separately. We're left with 3 ulcers now. So, chancroid and donovanosis, both are bipolar, both have drug of choice, azithral. Penicillin is the drug of choice for syphilis. So, now let's understand these kits. So, when I have a non-herpetic ulcer, right, we have to treat 3 things essentially by giving azithral and penicillin. So my kit 3 is white kit. Peace, white. I give penicillin 2.4 ml units 1 vial, and I give azithral single dose. Let's talk further. So as far as syphilis is concerned, let's club all the treatment. If it is primary syphilis, secondary syphilis, or early latent syphilis, for everything the treatment remains the same. You have to give benzathine penicillin 2.4 million units intramuscular injection stacked. That's it, one-time treatment. But if it is either a late latent stage where there are no symptoms but serology is positive, or tertiary syphilis except neurosyphilis, I am going to give same benzathine penicillin 2.4 million units, but now I have to give 3 doses, 1 weekly. So every week for 3 weeks we will give 1 injection. For neurosyphilis we will need, CSF penetration. So that's why intramuscular injection of benzathine does not cross the blood-brain barrier. So here I have to give aqueous penicillin. Aqueous penicillin, right? So this is what we need to remember here. 2 extra edge points. First, aqueous penicillin. This is what we call procaine penicillin. When we use procaine penicillin, you may have something called as Hoyne syndrome. Hoyne syndrome is a transient psychosis because of the procaine component. Little extra edge, very extra edge. Then, another very important question. They will tell you that a person with syphilis was treated with penicillin. Following treatment, the patient developed fever, patient developed myalgia and flu-like symptoms. Is this hypersensitivity? That's not hypersensitivity. This is what we call as Jarisch-Herxheimer reaction. This is basically because of release of cytokines. All of the spirochetes which are getting killed by the penicillin are releasing cytokines which results in these symptoms. So this is not a contraindication to penicillin, and this is not something which is indicative of hypersensitivity. All you have to do is give some NSAIDs and you are good to go. So that's one. Now, when you have hypersensitivity or allergy to penicillin, now what do? You replace that penicillin with doxy. That is kit blue. Remember, when you have hypersensitivity, you will turn all blue because of cyanosis. So that is blue kit where we replace it with doxy. So this is the very first kit where the treatment is not stat, right? What are we doing? We are doing doxy 100 mg for 15 days with azithral 1 gram stat. Okay, so this is if one is allergic to penicillin. What if somebody is pregnant and allergic? So pregnant plus allergic to penicillin. If they are pregnant, not allergic, give penicillin. Give the same kit, not an issue. But if pregnant and allergic to penicillin, now I cannot give the blue kit because doxy is a teratogenic drug. So here, what will be the answer? You will have to desensitize. You give small doses, repeated doses, and you desensitize to penicillin, and you have to give penicillin only. You can't give doxy. So every permutation combination now we have learnt. So these three ulcers are done. Herpetic ulcer, red base tha, red kit. This is where we use acyclovir 400 TDS for 7 days. This is a very important question. This is the only kit where we do not need to give partner treatment. For ulcers, all partners for past 3 months we have to give, and that makes sense. Remember, 9 to 90 days is the incubation period. So everybody who has come in contact for 90 days we'll have to treat. Yeah, so that's how you integrate concepts. You don't have to memorize it. So no partner treatment. Bubo is black kit. Earlier we were giving both. Now they have updated this to only doxy. So this is where you can remember BD. BD means bubo, you give doxy BD for 100 mg, right? 100 mg BD for 21 days. So this is what is BD, and all partners for past 3 weeks would be treated, and that makes sense. Why 3 weeks? Because it was 3 to 30 days. So we are basically covering for 3 weeks here. So this is inguinal bubo black kit. Then you have lower abdominal pain. So low abdominal pain is what is indicative of PID. This is what was asked in this year's INICT, that this is only to females. Obviously, only females are going to have vaginal discharge because only females have vagina. So this is what is pelvic inflammatory disease. Yellow is low. So this is yellow kit. Who will get PID? So you can remember, anybody with a big heart is having higher likelihood of developing PID. So big heart means DCM, dilated cardiomyopathy. So this is what is doxy, cefixime, metrogyl. So doxy given for 14. So doxy, let's see, I was giving for 15 days here, for 21 days here, and for 2 weeks here. All right. Then you have cefixime 400. So obviously wherever we have 4, we make it 8. So 800 mg OD stat, and metrogyl I told you is for 14 days. So metrogyl 14 days. So this is DCM. We now have another kit, which is the brown kit. So brown kit is for anorectal discharge or anorectal syndrome. So this is what is brown kit. Here what do? This is where you give a combination of 2 things. You give cefixime 800 mg stat, and you give doxycycline. So you give doxycycline here, it's for 7 days, 100 mg for 7 days. So you can actually remember ABCD. anorectal, brown, cefixime and doxycycline, right? So these are all the kits. Let's very quickly revise every kit. So we had kit 1, gray, urethritis, cervicitis, scrotal swelling, gonorrhea, chlamydia. What were we combining? Azithral 1 gram stat, cefixime 800 mg stat. Green kit, vaginal discharge. I had to target for 2 organisms, so I used secnidazole 2 gram stat and azole, fluconazole 150 mg stat. So then I went to ulcers. For every ulcer, essentially where I have no hypersensitivity, white piece, I gave penicillin 2.4 million units, I gave azithral. If there was hypersensitivity, blue, we gave doxycycline. Now we had to give it for 15 days, azithral 1 gram stat. Herpetic ulcers, red base, no partner treatment, acyclovir. Then we went on to bubo, black kit, right? So bubo black kit, BD. Kyuki bubo is bad, what do? We give now doxy for 21 days. We had yellow, low abdominal pain, bada dil, DCM. Doxy for 14 days, cefixime 800 mg stat, metrogyl 14 days. Then ABCD. Anorectal was brown kit, ABCD. Cefixime 800 mg stat, doxy for 7 days, right? So this is how you remember the kits without any mnemonic. Now we go into alopecia, super important. So when we talk about alopecia, if you know the causes of scarring, everything else is non-scarring. So just remember scarring alopecia. Our mnemonic here is TLD. T for tinea capitis. So tinea capitis, because it's inflammation, leaves behind scars. Lichen planus, I told you, leaves behind scars. DLE, discoid lupus erythematosus. Apart from these, there are 2 other causes. One of them is FFE, focal fibrosing alopecia. So that's not needed to be remembered because fibrosis is there in the name. The other one is this. This is where you see this footprints in snow appearance. Footprints in snow, that these patchy areas with scarring. This is seen in a very weird condition called pseudo-Pallard of Brock. This is just a variant of DLE actually, discoid lupus erythematosus, but you can remember. So these are 5 total causes, but I will suggest you to remember TLD. T, tinea capitis, lichen planus, DLE. We'll go into the details. So tinea capitis now. Let's dwell deeper into this first. So tinea capitis, the only tinea or only fungal infection where we still use griseofulvin. This is the only place where we still use griseofulvin. It's a microtubule inhibitor. So that's the first thing. We will talk about this. Let's do this right here, right now. So when we talk about tinea capitis, there are 2 variants of these tinea capitis. One is chirion and second is favus. Okay, so these are 2 variants of tinea capitis. So chirion is a very inflammatory tinea capitis where there's so much inflammation that all of your, KOH, Woods lamp, everything will be negative or normal. Why? Because the inflammation or the scars have destroyed the fungi also. So this is where they will describe tender, boggy swellings and there will be associated lymph nodes. So this is very heavy on inflammation. So that's chirion. This is what is caused by T. mentagrophyte and there is another species called T. verrucosum. So both of these are actually animal fungi, right? So these are not human fungi, these are animal fungi. So that is why there is a lot of inflammation from the human body, right? T. mentagrophyte particularly is a PYQ. They have asked this. So the hair perforation test is positive in T. mentagrophyte is what we need to remember here. Alright, apart from that, favus. So favus is where you see this crusting. You see scutula. So everything is so. So remember favus, scutula, crusting. And you know the cause, the most common cause is T. Schonleini. So just remember so. Everything which has an S is favus. Everything that does not have an S is chirion. So that topic gets finished with an S. In addition, one more Woods lamp. So favus particularly shows a dull green Woods lamp. So tinea capitis is usually asked, as a blanket statement. It shows blue-green or dull-green appearance. Particularly, it's favus, not chirion, which shows. So that's just one extra point. So 3 wood lamp, coral red, erythrasma, yellow, Tinea versicolor, blue-green or dull-green, Tinea capitis. So if you can remember this much, again, your match the following PYQ gets sorted because I know 3 now. Alright, on those lines, now let's just finish dermatophytes. What are dermatophytes? As the name suggests, these are fungi, superficial fungi which affect keratin-containing structures. 3 keratin-containing structures, skin, hair and nail. So let's see. There are 3 dermatophytes. You can remember telegram. Telegram hota hai 3. The short form of telegram is TME. So you have 3 dermatophytes. T is trichophyton. No need to remember the full form, just T will suffice. Just TME will suffice. So M is microsporum and E is epidermophyton. If you want to remember one, just remember trichophyton because it affects three things, all 3. So it can affect the skin. Everybody here can affect the skin. It can also affect the nail and it can also affect the hair. How does it affect the hair? You can see that these conidia are within the hair shaft. So this is what is endothrix. Because the inner part of the hair shaft is affected, this is what will result in a black dot appearance. So this is endothrix or black dot. Microsporum on the other hand now affects 2 things, skin and hair. So obviously this is where the conidia, can you see round things are outside the hair shaft. So this is called as ectothrix. Now when the fungi is outside, this is what is going to affect gray patch. It's going to be more confluent. And because the fungi are outside, this is the one which again shows Wood's lamp. So as a general statement, Tinea capitis shows blue-green immunofluorescence. But to be precise, it's ectothrix, kyunki bahar hai, it will show. Because it's outside, it will show. And it's favus, because chirion is too inflamed to show. Right? So these are the 2 specific pointers out of that heading. Then you can see epidermophyton. As the name suggests, this is not gonna affect now hair because hair is covered. So this affects skin and nails. Right? So these are the 3. Now you need to know the shapes. So you have macroconidia, you have microconidia. The shapes of macroconidia you can remember is PSC. PSC, primary sclerosing cholangitis. So TME, PSC. What is PSC? So T is pencil shaped, this is spindle shaped and this is club or civate shaped, right? So this is PSC. When we talk about microconidia, the number keeps decreasing. So you see them in T, it's plus minus in M, it's minus in E. So keep decreasing. Alright, so this is what is dermatophytes. Now what you have to remember are, so Tinea capitis is done, scalp. Then if you have it affected in the body, you are going to call it Tinea corporis, right? So you see these ringworms, annular lesions with central clearing. As we have discussed, any fungus, what do? We do a KOH mount, right? And you take a KOH mount from the periphery because that's where the inflammation is active, right? So that is Tinea corporis. Here you have to remember is, what is the drug of choice? Azoles. For any tinea, whether it's in the body, it's in the groin, it's in the feet, everywhere else in the body, you're going to use azoles. If by mistake somebody is given steroids, because you remember I told either give steroids or give azole, so they just heard the first part and give steroids. What will happen if you give steroids in a fungal infection is, now it changes the form. You can see how it does not heal, it becomes worse and it becomes unrecognizable. So this is called as tinea incognito. You know what is incognito? You know it very well. So this is tinea incognito, isn't it? So this is where when you give steroids in tinea, you will now have changing morphology, unrecognizable form, tinea incognito, right? So that's one thing. Then let's talk further about nails now. So nail inflammation is called onychomycosis. So onychomycosis is where you have the nail plate getting involved. So it's the plate that gets destroyed, and the most common type is what we call as DLSO. Distal, lateral, subungual onychomycosis. So sounds tough, but it's not. Distal, yeah, obviously it'll be distal, lateral and subungual. So that's what the most common form is. As far as the treatment of onychomycosis is concerned, again, this is the only form where I'm using old antifungals, right? Not azoles. So terbinafine is what can be used. How much to give? 6 weeks or 12 weeks. अगर fingernails affected है 6 weeks, अगर toenails affected है 12 weeks. So that's terbinafine. We also have some newer drugs. So these are two which are available as nail lacquers, like a nail paint. And these are also two more topical antifungals, right? So these are drugs which have been asked. So amorolfine is a PYQ. It's a nail lacquer. This big name, which we don't want to read, is also a lacquer. Tavaborol has been asked. T40 is topical, and this is a new drug which has been approved, efinaconazole. So just see this table once. These are the newer antifungals. All right, so this covers everything within dermatophytes. So where were we? We were at TLD. So that completes scarring alopecia. Everything else is non-scarring alopecia. So what does non-scarring alopecia include? Let's see. If they give you buzzwords, so now it's all about buzzwords. If I give you buzzword, keep following stress or pregnancy, means after your NEET PG, 3 months later, you start to have hair loss. What's the diagnosis? So that is telogen effluvium, right? So that's telogen effluvium. Chemotherapy. You can remember patients are getting chemotherapy. They will have to go in and out of the hospital. So उनका आना जाना होगा. So that's how you'll remember. Ana jana means anagen effluvium, right? So that's how you will not mix the two. If you have hair loss, particularly in the accessible areas, this is where you start to think of trichotillomania. So for trichotillomania, which is hair plucking, it's an OCD related disorder. It's not an impulse control disorder. We'll study this in psychiatry, right? So remember, it's not, because anything that ends with mania, first of all, it's not mania. It's usually an impulse control disorder, but exception is trichotillomania, which has now been, brought under the OCD related disorder, where you are having recurrent intrusive thoughts to pluck your own hair. So first, you can only pluck it from accessible areas. Second, they will give you a buzzword. There are broken hair follicles. Third buzzword, perifollicular hemorrhage, because you're pulling your hair and the hairs will be of various lengths. So 3 buzzwords, trichotillomania, super important. There's also this sign called as Friar Tuck sign. So this was a character, I think, in Robin Hood series. So this is where the hair loss is like this, on the top part of the head. So that is why this is called as Friar Tuck sign. And if you take it one step higher and you eat that hair, why waste anything, right? It's protein end of the day, it's keratin. So if you're eating that hair also, now it's not going to be absorbed. It's not protein. It's going to block your stomach and form this blob, which is called as a bezoar. So it can lead to gastric outlet obstruction like this. They can show you the CT. It's a trichobezoar. You'll see these black dots. So that's trichobezoar. Right? So this is, what is it? The other DD is phytobezoar. Happens in, pure vegetarians, lot of salad if you're eating. The salad will accumulate phytobezoar, right? So this is trichotillomania. Then we have to see androgenetic alopecia. As the name suggests, this is because of androgens. Even though it is because of androgens, it can happen in both male and females, but the cause remains androgens. So male pattern baldness, you can see, happens on the sides, happens on the occipital area. So this is what is called as the Hamilton pattern. And lady से हो गया Ludwig's. So Ludwig's alopecia is in female, where the scalp in the parting areas is what loses hair. All right, so male and female pattern. Because it's mediated by androgens, what do we want to do? So we have a topical treatment, we have a systemic treatment. The topical treatment that you will use for androgenetic alopecia is going to be minoxidil. Because it's a very toxic agent, we only use it topically. So it's either 2% or 5%. So in females, they write 2%, in males, they write 5% minoxidil. The only systemic agent that you have is finasteride. So if they ask you which systemic agent can be used, you will use finasteride, 5-alpha reductase. So that is 5-alpha reductase inhibitor. What that does is, it inhibits the conversion of testosterone to dihydrotestosterone, and ultimately it's dihydrotestosterone which is responsible for this alopecia. In females, you may also use anti-androgens. In males, you can't, because that will have other effects also, right? So in females, you can use anti-androgens as well, right? So this is about androgenetic alopecia. Next, we talk about alopecia areata. So, alopecia areata is also non-scarring alopecia. This is what is an autoimmune condition. You have autoimmune destruction of hair follicles. So based on that fact only you can tell me the treatment, right? Anytime something is autoimmune, what do? We use steroids. So you will start with topical as in intralesional steroids, and then if it doesn't respond, we can go on to systemic steroids, right? So the treatment for any autoimmune revolves around steroids anyways. So this is non-scarring. You can see this patchy hair loss without any scars. Because it's autoimmune, you will see these lymphocytes surrounding and destroying the hair follicles. So this is what is called as swarm of bees sign. All right. Apart from that, you also see this exclamation mark sign. So this is what you can see when you observe the hair, exclamation mark hair sign, where you can see that distally or at the lower aspect, it's wider. You know, how does an exclamation mark look like this? So this is how the hair is. It's wider near the base. So this is about alopecia areata. The nails, as we discussed, is regular pitting. Where did we study irregular pitting? That was psoriasis. And the patient here will come and tell you that he went white overnight. You have to tell him that you've not gone white overnight. Your black hair have left. So basically, this is a disease which does not affect the white hair. So the patient will feel only white hair, are left. So that is going white overnight phenomena. Few terms, not very important, but a little confusing. So I've put them. Totalis is total scalp. Universalis is all. So if you see universalis, you will understand. But when I give you just totalis, you may mix it. So totalis is scalp total, universalis is body total. Ophiasis is along the scalp margin, and Sisypho is reverse of Ophiasis. So Sisypho के नाम में है spares. So this spares the sides. So affect the side, O. Spares the side, So. That's all you have to remember. Let them remember the full names, right? So this is alopecia areata. So now we talk about something very, very important, particularly for INICT, and nowadays even NEET is asking a lot of questions. Very interesting, mosaico-bullous disorders. So here what we need to remember is where is the lesion. So if it is an epidermal lesion, we are going to name it pemphigus. And this is where what is involved are the desmogleins, right? So this is where desmoglein is involved. Pemphigus is the name, and this is where, because the lesion is superficial, the bullae are going to be flaccid. The buzzword here is flaccid. On the other hand, if it is a dermal lesion, this is where we are going to call it bullous pemphigoid. This is where you have affection of the BP antigen. We have two BP antigens, so BP antigen 2 is involved more commonly than 1. They have a separate weight. If you want to remember, the bigger number is smaller weight. So this is 180 kilodalton, whereas this is 230. All right, so this is 180, this is 230. So this is BP antigen 2 more than 1. But the important part is, because now this is a deeper lesion, the bullae are tense. All right, so that's at a macro level. Bullous pemphigoid, pemphigus. Let's go to pemphigus. Two types, all right. So, agar superficial hai, desmoglein 1, this is where you have a subcorneal split. Because it is so superficial, this is where you are gonna see erosions. Not even bullae, you're gonna see erosions. And the distribution is usually seborrheic distribution, meaning the trunk is involved, nasolabial folds are involved. What am I talking about? I'm talking about P. foliaceus. Because this desmoglein is not present in oral mucosa, we do not have mucosal lesions. So superficial erosions, desmoglein 1, subcorneal split, pemphigus foliaceus. First letter. Deeper 3, suprabasal split, meaning where is the split? What comes above basal? Lexus, spinosum, right? And we know spinosum has desmoglein, so obviously that's affected. So this is where you have desmoglein 3 affected. Both can be affected, 3 and 1, but if asked to choose, 3. So this is what is present in oral mucosa, and we have oral ulcers. And what is this? The most common, hence the name P. vulgaris. So this is pemphigus vulgaris. Now let's do the cousins. Who are their cousin brothers? You remember staphylococcal scalded skin syndrome. So Staph aureus exfoliative toxin affects desmoglein 1. इसका cousin कौन है? The cousin is SJS10, Steven Johnson 10, drug induced, affects desmoglein 3, and that's why it also has oral ulcers, right? So that's how you can remember how this does not have oral, this does has oral, right? So this is desmoglein 1, desmoglein 3. Bullous pemphigoid. You may have history of mechanobullous lesions, meaning bullae formation with trauma. That is epidermolysis bullosa. So epidermolysis bullosa can be either congenita, or it could be acquired. So obviously acquired is more common. This is where collagen 7 is defective. In congenita, there are 3 types. So you can see EB simplex affects keratin 540, which is epidermal. Junctional EB tends to affect integrin here, and dystrophic EB tends to affect type 7 collagen. So junctional can be integrin or laminin both, and dystrophic is type 7. So again, it's type 7 collagen which is most common. So this is where you can see this is your BP antigen, right? 180 matlab 180 कौन सा है? This is 2. So this is what is most commonly affected. So BP antigen 2 is upper, it's more superior, whereas type 7 collagen is inferior. But I can say both of these lesions are subepidermal, means both of these will have tense bullae. So how can I distinguish? For that, we have a special immunofluorescence called salt split immunofluorescence, where I create a cleft at the dermoepidermal junction. So now I am seeing that at this cleft, is the antigen here or is the antigen here? So because this antigen is upper, it's higher, the roof immunofluorescence is bullous pemphigoid, whereas floor is epidermolysis bullosa, particularly either acquisita or dystrophica, right? One way to remember this is, where do you drink BP? On the roof, right? So you can remember BP can be drunk on the roof. If you don't get that reference, you can remember BP will increase, right? It hits the roof. So whatever works for you, nerd version or spoiled person version. Okay, so this is BP roof. So this is about the targets. Now we talk about a few tests and a few images. So this is what is called as a Nikolsky sign. So in Nikolsky sign, what we are doing is applying tangential pressure. So I'm applying tangential pressure and we see that the roof is displaced. So this is what is going to be positive where? Obviously where the lesion is flaccid, right? So rather than remembering where it's positive, what is better? Better is to remember it will be negative in bullous pemphigoid because it's tense bulla, not easily ruptured, right? So positive, can I say? It would be positive in pemphigus. Can I also say both cousins? It would be positive in SJS10. It would be positive in staphylococcal scalded skin syndrome. So that's how you remember Nikolsky. Then we have a bulla spread sign. So in bulla spread sign, you again remember where is it positive? Again, pemphigus vulgaris. So pemphigus is where it's positive. Now we are applying pressure from the side. We are not applying tangential pressure, lateral pressure. So when we apply lateral pressure, you will see this angle. So when it extends with an angle, angular extension, that's called bulla spread sign, positive, seen in pemphigus. Then let's look at the histopath images here. What is it that you are seeing? Can you see there is a split? And where is it? It's just above the basal layer. So what do you think? Where do we have suprabasal split? It's down, desmoglein 3. So this is pemphigus vulgaris, desmoglein 3. And this is what is called as row of tombstone appearance. So these look like tombstone. That's fine. So this is suprabasal split. On the other hand, look at this. There is a split, but it is below the epidermis. So this is at the dermoepidermal junction. Can you observe that? So this is bullous pemphigoid. The split is deeper, dermoepidermal junction. So these are a few images. Little extra edge, you can have drug-induced pemphigus, which is caused by penicillamine, captopril is ACE inhibitor, and rifampicin. Extra edge, never been asked. Paraneoplastic, you just want to remember the most common causes, non-Hodgkin's lymphoma like CML, right? So you can just remember that it's a paraneoplastic pemphigus. If this comes, party, okay? Then there are a few more types also. Let me address that first and then we look at more images. So bullous pemphigoid, as we discussed, is BP antigen, right? So this is both BP antigen 2 more than 1. So 180 and 230. But these two, so your linear IG and cicatricial is only BP antigen 2, which is 180 BP antigen, right? So this is where you have bullous pemphigoid. Another version, so pemphigus in pregnancy or bullous pemphigoid in pregnancy is called pemphigoid gestationis, which is fine. But you know what it was called previously? It was called herpes gestationis. Gestationis makes sense, but why herpes? So I don't know why there is, these misnomer with herpes everywhere. Impetigo herpetiformis, dermatitis herpetiformis, herpes gestationis, and all three have nothing to do with herpes, right? So that's, what is there. So this is BP antigen both 2 and 1. This is linear IgA cicatricial, meaning scarring, only 180. So these are just types of tense bullae. Coming to important images. So when you see this, flashcard, what do you think of? You are seeing flaccid bullae. You are seeing oral ulcer. So what does that tell you? That tells you pemphigus vulgaris. Because this affects desmoglein within the epidermis, what is this test? First of all, this is direct immunofluorescence. It is the investigation of choice for pemphigus and pemphigoid group of disorders, and direct immunofluorescence is going to show you a fish net appearance. But if they ask you what is the first test you will do, the first test you will do is the Zank smear. So Zank smear, remember, is taken from the floor of a bulla, whereas direct immunofluorescence is taken from the margins, because that's where you have active inflammation. In the Zank smear, you already know we are going to see acantholytic cells, right? So the first investigation, Zank smear. Direct immunofluorescence is what we are going to see from the margins, fishnet appearance. Apart from this, you'll also remember that direct immunofluorescence is going to pick up on IgG and C3 deposition against the desmogleins, right? Now look at this. You can see how tense the bullae are. Tense bullae. In addition, they can also give you erythematous base. The base here would be red, very much similar to herpes ulcers that we study. And you may see eosinophils, right? So this is where you may see eosinophilic microabscesses, and that's why there's a lot of itching which is associated here. So those are a few buzzwords. Itching, red base, tense bulla. Because this is a dermo-epidermal junction, look at the direct immunofluorescence. Again, you see IgG-C3 deposition, but now at the dermo-epidermal junction targeting the bullous pemphigoid antigen, BP antigens, right? For both of these, the treatment of choice is going to be steroids, and you may use steroid sparing agents like cyclophosphamide as well. So those are called as steroid pulses. So this is for these two. Now we talk about Ig related diseases. So this is where direct immunofluorescence shows us linear IgA, something that we studied here, BP antigen 2 being the target. So this is where you have IgA deposition, also called as chronic bullous disease of childhood. So this is what affects children, and you will see these ulcers around the orifices, and this is what is called as a string of pearls appearance. All right, so this is linear IgA disease. All right, so this is what we are seeing here. And look at this. So this is one more misnomer now that we were talking about. This is where we have IgA deposition, but now this is at the papillary tips. This is called as a picket fence appearance. So picket fence, papillary tips, IgA, and this is where at the papillary tips you may also see neutrophilic micro abscesses. All right, because of these abscesses you see a lot of itching, and that's why the misnomer dermatitis herpetiformis, they will say that there are these red itchy lesions on the extensor surfaces. Because it is itchy, they call it dermatitis. Because it is red, it is called as herpetiformis. So this is one more strong misnomer, dermatitis herpetiformis. Super important association is celiac disease. You know celiac disease, you have transglutaminase, right? So tissue transglutaminase. So here the target also is epidermal transglutaminase 3. Okay, so this is where the target is transglutaminase 3. So you can do serology tissue transglutaminase for celiac. You know how to treat celiac disease? You avoid gluten. So you avoid brow. What is brow? You avoid barley. Just remember, R is not rice, it's rye, oats and wheats, right? So this is what you have to avoid in cereal for, these patients. Apart from that, wherever you see IgA, you can treat it using Dapsone, right? So the treatment is Dapsone for these two. So this is what we need to remember as far as the Vasico-Bullous group of disorders go. From this point onwards, now our focus is mainly on pictures, right? Flashcards. The major group of disorders we've already completed. Now just, few niche topics we have to do. Let's start with disorders related to drugs. Very important. Somehow pharma and skin have a very intrinsically strong relationship. Let's explore that. So this was asked in INI November 2025. You can see that there are these lesions with this halo sort of a thing. Hyperpigmentation affects face, extremities, genitals. So this is where we have fixed drug eruption. The drug is fixed, the site is fixed. So they will say after taking the same drug, every time there's a lesion at the same site. Fixed drug eruption. This is what is a type 4 hypersensitivity, right? And this is happening mainly because of use of NSAIDs most commonly, can also be reported with metronidazole. So this is fixed drug eruption, and the repeat question here is it leaves behind hyperpigmentation. So there can be residual hyperpigmentation, just the image based question gets asked here. Okay, then you took a drug following which there were these diffuse, bullous lesions, oral ulcers, desmoglein 3. What was the cousin? This is SJS 10. Steven Johnson syndrome, toxic epidermal necrolysis. 10 is not 10, meaning SJS is less than 10% body surface area, whereas 10 is when it's involving more than 30% body surface area. 10 to 30 is what is called as an overlap syndrome. So that's SJS 10, frequently reported with anti-epileptic drugs like lamotrigine, carbamazepine, right? So that's where it's reported. Also been reported with allopurinol, NSAIDs and sulfa drugs, right? But the most important group being anti-epileptic drugs, and there is the score also, score 10. It's there in the name itself. It's a score of 10, right? So this is a severity score, prognostic score. So this is SJS 10. Then you can see this is where you have a morbilliform rash. Whenever you see this morbilliform, meaning measles-like appearance of a rash, think of two things. One is a very niche condition. Let's say somebody has infectious mononucleosis, which is because of EBV, and you gave them amoxicillin thinking it is strep. So that is where they worsen and they develop this morbilliform rash. So amoxicillin in EBV, that's first DD. The second DD is where you will think of something called as DRESS syndrome. So what is DRESS syndrome? So as the name suggests, this is drug related. There is eosinophilia and there are systemic symptoms. So this is where the history will be a rash, which is because of a drug, along with eosinophilia and systemic symptoms, and this is also associated with anti-epileptic drugs. Spotter, PYQ, this is flagellate dermatitis. We've studied this in anti-cancer as well. What is this? This is because of bleomycin. Then you can see blue man syndrome, blue matlab ceruleus. So this is ceruloderma. Tell me the cause. Amiodarone. And when you see this livedo reticularis appearance, net appearance, reticular, remember lichen planus, reticular, livedo reticularis, this is amantadine. We use it in Parkinson's. We have studied in neuro. It's an add-on drug for Parkinson's. So this is what we have. Then a few one-liner questions here. Red man. Where do we study red man? That's vanco. Why in vancomycin? It's because of histamine release. So that is why it can be controlled by giving antihistaminics. So that's red man. Gray baby is chloramphenicol. This is a teratogenic effect. Pseudo jaundice is rifabutin, right? This is what we have replaced rifampicin with in when we want to give ATT and ART together. So that causes pseudo jaundice. Apart from that, even beta carotene, if it is increased, too much green vegetables, carrots can lead to carotenemia, which is pseudo jaundice. Skin and nail pigmentation, ART drug, tell me, zidovudine, right? All of this we will cover in antiretrovirals. So this is zidovudine, whereas palms and soles, emtricitabine. So both of these are your ARTs, emtricitabine. Hand-foot syndrome, this is 5-fluorouracil and its oral prodrug which is called as sapecitabine. So this is the oral prodrug. So 5-fluorouracil, sapecitabine. Purple toe syndrome, what is purple toe? So purple toe is warfarin, right? So this is where we have studied we should always give warfarin with heparin cover because it will first block protein CNS which may cause coagulation before it has its anticoagulant action. Purple glove is phenytoin, where you also have pseudo-lymphoma or lymph node enlargement. Vesicular eruption, barbiturates may have that. And ichthyosis and copper, this is a PYQ. Clofazimine, where did we study clofazimine? RDC, rifampicin, davzon, clofazimine in leprosy, right? So this causes CCC, copper and ichthyosis. So these are all your drug-related things. Now let's talk about dermatitis. First we'll talk about contact dermatitis and then we talk about atopic dermatitis. Whenever I say dermatitis, it's basically gonna mean a lot of itching. There's a vicious cycle which is itch, scratch, itch. You have an itch, you scratch it, you have more itching because of that. So that's the vicious cycle that happens. So contact dermatitis, look at this. What is this? If I show the hands and I tell you a lot of detergent exposure, is this irritant or allergic? This is irritant. Irritant contact dermatitis is not a hypersensitivity. It is because of the detergent. It will happen in all of us if we use that detergent for long enough. But this is allergic contact dermatitis means this is a type 4 hypersensitivity. This will only happen in those who are predisposed. If all of us wear an artificial ring with nickel, all of us are not going to have this, but only ones who are allergic is going to have it, right? So that's allergic contact dermatitis. Nickel happens to be the most common allergen that is found in artificial jewelry. Other allergens, chromium. Chromium is found in cement. PTBP has a B in it, B for bindi. So this is what is found in bindi adhesives. This has been asked. PPD, also PYQ, hair dyes. This is what is found in hair dyes, common allergen. Neomycin is what is used in a lot of topical ointments and you may have an allergy to that. It's because of neomycin. This one is not so much of an allergen as much as it is a leucodermic agent. So this is what leads to contact leukoderma. This is what is found in rubber, So look at this image. You can see how there is depigmentation along the margins of the rubber slipper, right? So it's because rubber contains this hydroquinone. And that's why hydroquinone is commonly prescribed, if somebody has a scar or you want, depigmentation, they use hydroquinone for that. So this is what causes contact leukoderma. So this is irritant and allergic. Because this is allergic, what we do here is this patch test. You will club the common allergens and you will see whether there's hypersensitivity or not. So this is what is the patch test and it is read at 48 hours and 96 hours. If you are asked to choose one, you will choose 96 hours, right? So this is what is the patch test for irritant or allergic contact dermatitis. Allergic because there is no hypersensitivity in irritant contact dermatitis. Then you have this particular condition that's called ABCD. ABCD meaning airborne contact dermatitis. So this is what happens because of this plant, Congress grass, which is Parthenium, and in that the antigen here is this particular thing, sesquiterpene lactone, unpronounceable, unrememberable thing. We will mark it when we see that in the option. So this is ABCD. The only thing is it will be affecting, the areas that are exposed to the air. So that's the only clue here. So these are your contact dermatitis. Atopic dermatitis is where problem is not outside, problem is within you, right? So that's atopy. You are predisposed to it. So atopic dermatitis, as the name suggests, is a type 1 hypersensitivity. So this is where you have a Th2 response. Th2 response matlab type 1 hypersensitivity, eosinophilia. So that's associated with atopy. So this is what the criteria is. Hannifin and Rajka criteria. There's major and minor. Let's just do major. It's a triad of atopy. There is chronicity. It's not a triad. There are 4 things. So it has to be chronic, associated with atopy, associated with a lot of itching, and typical location. What are the typical locations? So now see, in infants till around 2 years, you will write face like this, meaning it affects the face of babies and it affects the extensor surfaces. As the child grows, now you write face, meaning it will affect the face and it will affect flexural surfaces. And as you grow older, it is just flexural surfaces, right? So face, and fur is how you will remember the progression. As we discussed, in acute itching, you will have redness, you will have spongiosis. Remember, intercellular edema, you'll have weeping lesions, vesicle, crusting. As you keep itching, it becomes scaly, and finally, this is a sign of chronic lichenification, right? So this is chronic itching, secondary lesion like we studied earlier. Then let's talk further. So you have this Denny Morgan fold. So these are the folds below the eyes. So this is the Denny Morgan fold that you see in atopic dermatitis. There are a few more named appearances like headlight sign where there is pallor, right? Facial pallor. You may have shield cataract, which can be both anterior or posterior subcapsular cataract. Don't mix it with shield ulcer. That is vernal keratoconjunctivitis, right? So that's something that you mistake. So I'm just going to write it versus shield ulcer in VKC. You may also have keratoconus associated. So these are associations, pretty important. The treatment, because it's a hypersensitivity, we want to give steroids. We may use calcineurin inhibitors as well. 2 new drugs, just remember, one is PD4 inhibitor, crisaborole, and duplimab. We also study in asthma. So 4 is D, 4th letter is D, so dupli, that can be done. Alright, so this is atopic dermatitis. Then we talk about histamine related diseases. So 3 histamine related diseases. The first one, very important, is urticaria. So urticaria is where you are going to have these transient dermal edematous lesions. As we discussed, these are called wheals, right? Not annular lesions. You may also write and you will see that the red letters come up. That's dermographism. And again, it's type 1, so it's histamine related. This one is a special type of urticaria called as cholinergic urticaria, meaning wherever there is sweating in hot areas, if you sweat, you have these reddish wheals. And this is important. This sign has been asked just in this exam, November INI. So this is Darier's sign that when you just scratch, you're going to have this reddish wheal. So this is what we see in cutaneous mastocytosis. As the name suggests, it's a mast cell proliferation, and that's why too much histamine release. So that's Darier's sign, and this is associated with c-KIT mutation, right? So that's cutaneous mastocytosis. Something which looks like histamine mediated but is not is this condition. So this is what is hereditary angioedema. So hereditary angioedema is a defect of C1 esterase. So this is where you have a C1 esterase inhibitor deficiency. So it's C1 esterase inhibitor deficiency, because of which there is overactivation of the C1 esterase and all of the complement pathways are on an overdrive, because of which the levels of C4 are low. It's mediated through bradykinin. So it's not histamine, it's bradykinin, and unfortunately it is the same role as histamine, leads to increased vascular permeability and vasodilation, because of which you will see symptoms like angioedema, but this is where you do not have wheals, right? So this is what we see here. The drug of choice, you can give C1 esterase inhibitor, right? So you can give C1 esterase inhibitor directly. Also remember, this condition is autosomal dominant. New drugs, lots of names here, write this in choti copy. So you have plasma kallikrein inhibitor. So plasma kallikrein inhibitor, cal inhibitor. Lanadelumab, you can remember lanadelj, berotralstat. So this is also stat. Bradykinin antagonist, this is in the name itself, bradykinin antagonist. So at least cal inhibitor, stat, and lanadel and bant. So pretty like tolerable names. You will see them 2-3 times, you will remember, right? So this is hereditary angioedema. Then we talk about acne. So you know the various stages of acne. What is acne? First of all, is the obstruction of the pilosebaceous unit. Remember our very first page where we talked about pilosebaceous organ? So that unit gets obstructed. You may have secondary infection of that, and that is usually caused by bacteria of the skin like Propionibacterium acnes, right? So this is how the progression happens depending on the stage of obstruction and inflammation. So it starts off as comedones. Now these comedones are what we call as whiteheads or blackheads. So this is either open comedones or closed comedones. Now when the comedones are open, they are open to the atmosphere, so there is oxidation of the sebum, because of which it becomes black. But if it is closed, it is white. As it progresses further, they can become raised to become papules. If and when there's a secondary infection, there can be pus. They become pustules, and the severest stage is when you have this nodulocystic type of acne. So this is how the progression happens. That's how you have to understand treatment also. So how do we treat? We keep stepping up. So the treatment of comedones is going to be topical retinoids. So what are the retinoids that we typically use here? So we can use tretinoic acid or tretinoin, or you can use adapalene, right? So these are what are topical retinoids. If it progresses to papules, so in addition to topical retinoids, now you can add topical antibiotics. Topical antibiotics like Clinda, right? So you can add clindamycin. If it progresses to pustule, means now there is infection. So now I have to give oral antibiotics, typically doxy, right? So doxycycline is what is given. Doxy or azithral can be added. So doxy. Now if it becomes nodulo, then the drug of choice becomes isotretinoic acid. So this is where now you can't keep adding. Now you bring the big guns, that's isotretinoic acid, oral isotretinoic acid. Alright, so how did we understand the treatment? Topical retinoids, topical antibiotics and oral antibiotics. At any stage, you may give benzoyl peroxide as well. You can give salicylic acid face washes, benzoyl peroxide face washes, that can be added, right? So now let's talk isotretinoic acid. So oral isotretinoic acid, this is where the washout period we learned was 3 months, meaning for 3 months we have to avoid pregnancy. So pregnancy has to be ruled out, and you have to counsel the patients in reproductive age group female. So that's one, that this is very teratogenic. Apart from that, this has a few side effects. Cheilitis is what is the most common side effect. So lip and inflammation. Apart from that, it can increase triglycerides. So you must monitor their lipid profile, and it is also hepatotoxic. toxic. So you should monitor UPT, LFT, lipid profile if anybody is on isotretinoic acid. Apart from that, another indication is it's been more than 6 months of treatment. You have no response, you can use isotretinoic acid. So these are two indications. Any resistant acne. Any resistant acne, always rule out underlying hyperandrogenism. This is a PYQ. Apart from that, two DDs now for acne. One is rosacea, which I will deal with, and the second one is drug-induced acne. So drug-induced acne, common culprits include steroids. So steroids can lead to drug-induced acne. Steroids can also lead to dermal atrophy. So both of these are PYQs. Even lithium we have seen can aggravate any skin condition including acne. So this is drug-induced acne. The difference is there are no comedones here. And second, it is not polymorphic like your acne. This is monomorphic. So you will see all forms being the same, right? So no comedones, monomorphic. The treatment is just stop that drug, right? So two buzzwords. The second DD is rosacea, right? So there are two females here. Who has rosacea? This one. So here now you have one more DD at play, which is a malar rash. A true malar rash, butterfly rash, is gonna have sparing of the nasolabial folds. So you can see the nasolabial folds are spared here. This is what is Esselica malar rash or a butterfly rash, whereas this is what is rosacea. What is rosacea? So this is where you're going to have these papules, but there are going to be telangiectasia. So versus acne, rosacea is going to have telangiectasias. Rosacea will have no comedones. And you will see triggers. So you're going to see triggers such as, hot, spicy food. You may have alcohol as a trigger, emotional disturbance as trigger. So that's rosacea. And here also it's the sebaceous glands, which come into play. So these are the stages. So this is acne, rosacea, malar rash, drug-induced acne, right? Now we go into pigmentation disorders. So first I'll deal with hyperpigmentation disorders and then we talk about hypopigmentation disorders. So hyperpigmentation disorders can be divided into dermal and epidermal. So when you have epidermal, look at the topmost row. This is what is epidermal pigmentation. Epidermal pigmentation, two things. One, it looks brown. All right, it looks as brownish macules. And second, if you do a Wood's lamp, you are going to see that they are exacerbated. They'll be, more prominent. But if it is a dermal pigmentation, the color becomes either blue to slate gray. And that is because of something called as Tyndall effect, right? The spreading through the light. So this is blue or slate gray and this will not be, exacerbated on Wood's lamp. So that's how you distinguish. So see the top row, this is all epidermal pigmentation. You can see on the nose, very common in the Indian subcontinent, this is what is called as melasma. So melasma can be seen in photo-exposed areas. One of the common causes are pregnancy or thyroid disturbance. Particularly when it's seen in pregnancy, we call it cloasma, CP. So cloasma particularly for pregnancy, or you can call it melasma. Here they'll give you history of a viral fever, arthralgia, retroorbital pain. What is this? So this is the pigmentation that is seen in chikungunya. Nose is involved and this is called as chick sign, right? So this is what we call as chick for chikungunya. Then you have this nevus, the boy is called Becker. So this is Becker's nevus with hair and pigmentation. So these are epidermal. Three dermal pigmentations frequently seen in children in the Asian subcontinent. So this is Mongolian spots at birth. These are seen, usually regresses by 2 years. You can see how it has a bluish coloration because of dermal pigmentation. Orbit में है, this is called as nevus of O for orbit, O for ota. If it is on the scapula, EAT, bricks we carry on the scapula, this is called as nevus of Ito. So ota and Ito. So this is about dermal pigmentation. Two more terms you want to remember: freckles versus lentigens. First of all, write them in alphabetical order. Freckles is more melanosome activity, vowels or first letter. This is more melanosome number. So freckles is more melanosome activity, commonly seen in Caucasians, where they will have a lot of freckles on the face, also called as ephelites. This we study in Name syndrome. Nevi, you have ephelites, and what is AM? Atrial myxoma, right? So this is what are ephelites, commonly seen in xeroderma pigmentosa, which is a nucleotide excision defect, right? So that's activity. Lentigens we have studied in Peutz Jeghers, right? You can see these lentigens which are present in the mucocutaneous area around the lip. So this is freckles and lentigens. Let's talk about hypopigmentation now. So look at this complete absence of pigment. This is albinism. What went wrong here? The melanin pigment was not formed because there was no tyrosinase. Tyrosine to melanin. Remember, in biochemistry we'll do this. No tyrosinase, no melanin, right? So this is what is albinism. You will remember that this is oculocutaneous albinism, and this is where you have the inheritance, which is commonly autosomal recessive. So no melanin. Then you can see this. This is what was asked in NEET 2025. This is nevus depigmentosus. Now, a very, very important consideration here is vitiligo. How is this different from vitiligo? One, this is congenital. Second, this is what is non-progressive. Vitiligo, on the other hand, is going to be an acquired form. It's an autoimmune condition and it progresses, right? Apart from that, a few buzzword would be how this lesion looks. Can you see how it has these satellite margins or this feathery margins? So nevus depigmentosus is a lesion, congenital lesion, non-progressive lesion, and the problem here is the melanocytes cannot distribute the melanin equally to the keratinocytes. So it's a defect of distribution of melanin. So that is nevus depigmentosus. It is non-progressive, congenital. Do not mix this with nevus anemicus. Nevus anemicus is not even a true hypopigmentation lesion. It is where you have alpha 1 receptor defect. Because of that, you have vasoconstriction that happens. Alpha 1 receptors are very sensitive, and that vasoconstriction results in the blanching actually. So it looks like a nevus, but it's not a true nevus. So that's nevus anemicus. Then look at this two lesions where you may have white forelock of hair. So look at this bunch of hair here. This is called white forelock. This can be seen in two conditions, two buzzwords we have to think. If I say the buzzword as islands of sparing, so white forelock with island of sparing, you will think of piebaldism. Piebaldism is what is an autosomal dominant defect, and the defect here, the mutation is a c-KIT mutation. Where else did we study cutaneous mastocytosis? This is also c-KIT mutation, and this is where the problem is the neural crest cell did not really migrate or convert into melanocyte. Remember, neural crest cells had to differentiate into melanocytes. They did not differentiate. All right. And where you have heterochromia iridis, so this is heterochromia iridis. This is also a defect of neural crest cell only. This condition is what is called as Waardenburg syndrome. So this is Waardenburg syndrome, heterochromia with white forelock, and this is also autosomal dominant. This is because of PAX3 mutation and same defect in both of them. It's a problem of neural crest cell. So white forelock, neural crest, common themes. अगर है island of sparing, think of piebaldism. Piebaldism, in the name only somewhere you can find island, isn't it? अगर है heterochromia, think of Waardenburg. They look so beautiful actually. So everybody says wow, so unique. So you remember wow. All right. So this is what we have. Look at this appearance. Looks like a marble cookie, isn't it? So hypo and hyper. This is what is called as hypomelanosis of Ito, not nevus of Ito. Hypomelanosis of Ito, where you have this hyperpigmentation along the Blaschko's lines. So these are what are the Blaschko's lines, which are the lines that represent the embryological origin of the skin. So on that lines, let me first teach you these lines and then we go back to vitiligo. So here what do we see? So you have to identify three lines now. So where you see they meet in the midline, curved sort of lines, meeting in the midline is what you look out for are Blaschko lines. Blaschko lines are what represent the embryological origin of the epidermis. On the other hand, where you see these horizontal lines not meeting in the midline, these are what are called as Langer's lines. Langer's lines represent the orientation of the collagen fibers. So if I have to give any skin incision, I'm going to give it along the Langer's lines, right? So that's Langer's. On the face, you have these Krasel's lines. All right. So these are also called as relaxed skin tension lines. When I'm not speaking, I'm at rest. The lines on the face used by plastic surgeons are called as relaxed skin tension lines or Krasel's lines. So these are just, one-liner questions that can be asked. So Blaschko lines, we studied hypomelanosis of Ito. Another condition that can happen along the Blaschko lines is incontinentiae pigmenti. So incontinentiae pigmenti is a condition which is one, X-linked dominant. The gene that is mutated here is the Nemo gene. First of all, X-linked dominant. Very few conditions are X-linked dominant. You can remember Ravi. What is Ravi? So R is Rett syndrome, A is Alport syndrome, V is vitamin D resistant rickets. So this is where you have a P hex mutation. This is also called as hypophosphatemic rickets, and I is incontinentiae pigmenti. A lot of times even retinitis pigmentosa is described. So this is your Ravi, which is X-linked dominant. RP and Rett, Alport, V for vitamin D resistant or hypophosphatemic rickets, and incontinentiae pigmenti. Right. So this is where you have four stages. Look at the first one. This is where it starts off with vesicular lesions, progresses to become verrucous lesions. Then you can see a hyperpigmentation phase, and then you have hypopigmentation phase. So they can ask you to do a sequential arrangement here, never been asked so far, but this is also happening along the Blaschko lines, right? So this is about the lines concept. Now let's talk about vitiligo. What is vitiligo? Is an autoimmune condition again. So vitiligo is where we have autoimmune destruction of melanocytes, right? So this is where the melanocytes are destroyed. You saw albinism where there was no melanin production. We saw these conditions, right, where we could see that the melanin is not getting distributed. That's nevus depigmentosus. And this is where the neural crest cells were not forming into melanocytes. So all of these are the causes of the pigment disorders, and this can come as a match the following type of question, never been asked so far, right? So now let's talk about vitiligo. So here there are the various types. Now normally vitiligo is divided into segmental and non-segmental types. So segmental vitiligo is what is this example. This is a PYQ. So this is where the vitiligo patch extends to involve a complete dermatome, right? So there is complete dermatomal involvement. So this is the type which is considered to be the stable type. What will happen is it will keep increasing until it involves the dermatome and then it stops. So that's what was asked once. So this is segmental vitiligo. What are the other non-segmental types? So this is focal vitiligo, where there's just one patch, not dermatomal. Then you can see this is acrofacial. So acrofacial, face and extremities are involved. The most severe part of this is lip tip, where the lips and the tip of penis is involved. Both of these types poor prognosis. Then you have vitiligo vulgaris. As the name suggests, bilaterally symmetrical. This is what is the most common type. And then you have vitiligo universalis, where almost the entire body is involved. The normal part actually stands out here. So these are the different forms. So obviously universalis has a bad prognosis and acrofacial has bad. In addition, long standing bony prominences involved, white hair, lip tip are all having bad prognosis to treatment. They don't respond well to treatment. The treatment obviously again becomes topical steroids. If it doesn't respond or the involvement is more extensive, we can give systemic steroids. In addition, you can also use calcineurin inhibitors like cyclosporin. More commonly what we use is tacrolimus, right? So that's tacrolimus. Then we talk about nevi. Again, not very important for us for Indian exams, but just for completion's sake, let's see. So we have junctional nevus. As the name suggests, now the melanocytes from the stratum basale are at the dermoepidermal junction. As we keep going down, you will see that it becomes more and more lighter. So this is dark. So this is junctional nevus. Compound nevus, as the name suggests, is at the dermoepidermal junction and now it's gone into dermis as well. So this is what is elevated and the pigmentation has decreased. So as the pigmentation decreases, you see the elevation increases. So junctional is flat and dark. Compound is lighter and elevated. And intradermal you can see is dome shaped and it's completely light. So this is where there is no melanin at the junction, only in the dermis. So remember these three together: junction, compound, dermal. Then you have congenital melanocytic nevus. Since birth, you may have hair associated. So this is where we need to learn about giant CMNs. Congenital melanocytic nevus is defined as any nevus more than 20 centimeters and they have a higher risk of turning into a melanoma. They have a higher risk of turning malignant. Then you have halo nevus. So this is where you have this depigmented halo and that is because of lymphocytic infiltration, and you may have dysplastic nevi which are on their way to become melanomas, right? So not much in this except for junctional, compound and intradermal. Then let's talk about skin malignancies. So here we need to talk about basal cell carcinoma. So basal cell carcinoma is the most common skin cancer in India. So basal cell carcinoma, this is the typical morphology, above the lip, near the eyes. You will see this margin. This is also called as a rodent ulcer. From RO, you can remember rolled out margins, and you can remember pearly edges. So it has pearly edges, rolled out margins, very well defined lesions around the face, photo exposed areas, and this is also previous year question. On histopath, you see true palisading. True palisading means cells layered over one another. Where do we see pseudo palisading? We'll learn this in brain tumors. That's glioblastoma. So you can correlate here. Pseudo-palisading, serpentine necrosis. This is what we see in GBM, glioblastoma multiforme. Basal cell carcinoma is associated with sonic hedgehog mutation. So you can give these inhibitors called vismodegib, new drug, and the treatment of choice is Mohs micrographic surgery, where you need not do a wide local excision. You can just remove this lesion, right? So basal cell carcinoma does not really show you metastasis or lymph nodes. Okay, so this is very good prognosis. Then look at this, where you see, this nodular lesion, keratin pearls are described. This is squamous cell carcinoma. Squamous cell carcinoma, remember keratin pearls. History of sun exposure, higher age, there could be immunosuppression. In fact, this is the most common skin cancer post-transplant, right? This is what can happen because of chronic wounds. What do we call that? We call it Marjolin's ulcer. It could be secondary to burns, could be secondary to arsenic exposure. All right, so these are the risk factors, seem a little important. So any chronic wound becoming a cancer, think of squamous cell. Then you may have melanoma. So melanoma, uncommon in India, but let's remember ABCDE rule. Any nevus that has asymmetry, borders become uneven, color becomes uneven, has a diameter more than 6 mm, 6, and evolving or changing. Always rule out a melanoma. So that's ABCD. However, the most important prognostic factor here is the depth. So that is what we call as Breslow's depth. So Breslow's depth is the most important prognostic factor for melanoma. In India, the most common site is acral. So the extremities are most common. This was your I9 November 25 question associated with BRAF mutation. That's why you can give BRAF inhibitors, vemurafenib, and cyclin dependent kinase 2A. That's just extra. So types of melanoma, overall in the world, the most common type is superficial spreading. This is what the example is, uneven borders. Lentigo maligna, as the name suggests, is having more radial spread. Radial spread as in not depth but radial. Whereas nodular, as the name suggests, has more depth to it. Whereas acral is what is most common in Asians or Indians, right? So superficial spreading is most common overall in the world, but in India we have the acral type that's more common. So that's all we need to know about melanoma. Three particular lesions that you see here. When you see the scaly lesions, particularly in the photo exposed areas, think of actinic keratosis. So this is actinic keratosis, scaly photo-exposed areas. Is this pre-malignant? Yes, it is. It is pre-malignant, can convert into squamous cell carcinoma. On the other hand, look at this. This is what is called as seborrheic keratosis. SK. SK, sickle stuck on. This is what is described as a stuck on appearance. This is not pre-malignant. But what is important is if there are multiple, this is what we call as sign of lesser Trellat, and that may represent an underlying malignancy. So this is what is a sign of paraneoplastic syndrome. And what do we have? Adeno-CA. So since this class, we have learned 3 paraneoplastic, all related to adeno-CA. We did acanthosis nigricans, we did seborrheic keratosis, and we did one more. So what are the paraneoplastic things? We studied acanthosis, dermatomyositis could be paraneoplastic, and seborrheic keratosis, right? Sign of lesser Trellat. Now look at this. This is what is the plug. It's a keratin plug, right, which will be shed off. So this is what is called as a cutaneous horn and also called as keratoacanthoma. Acantho meaning spine. So there is a spine in the center, right? This is not pre-malignant. It can completely be shed off. Alright, so this is keratoacanthoma. So these are 3 lesion spotters. Now let's talk about vascular tumors. So first we are seeing all the benign lesions. So this is what is called as an infantile hemangioma. As the name suggests, it is in infant, right? So because it's in infant, it is going to regress. It's gonna, spontaneously regress or involute. So you can remember infantile involutes. Alright, so this is present at birth, it will grow for some time and then it usually regresses. So it may increase initially, but then by around 6 to 8 years, it usually regresses. So may increase initially, but then it regresses. So that's infantile hemangioma. This is also called as strawberry hemangioma or stork bite, right? So this is what is to just, tell and reassure parents that your child does not really have a tumor. Imagine telling your child has a vascular tumor. No, so that's why you have, toned it down, said, no, a stork has bitten your child. You have a strawberry, so they are chilled, right? So this is what is infantile hemangioma. On the other hand, when you see what looks like infantile hemangioma, but in an adult, so this is what is a cherry angioma. From strawberry, we have gone into cherry. So this is what is seen in adults. It is essentially a form of capillary hemangioma, right? So it's capillary. The counterpart of this is cavernous hemangioma that is seen in solid organs like the liver. So this is something which is not gonna involute. So this is gonna remain the same size. It's a benign lesion. So strawberry, cherry. Then if you see the nail bed, very, very painful red lesion they will describe in the nail. This is what is called as a glomus tumor. This is an organ in the nail bed that is responsible for thermoregulation. So exquisitely painful is what they will describe here. This is glomus. And what has this pedunculated sort of an appearance? History may they'll give you pregnancy. So what does that tell you? This is pyogenic granuloma. Alright, so this is also called as pyogenic gravidarum. So pyogenic granuloma, that is typically seen in pregnancy, so has a stalk, right? So these are benign lesions: strawberry, cherry, glomus, and pyogenic. Other lesions, other vascular lesions. So look at this. This is what is linked with HIV. So in both of these, they are going to give you history of HIV. Look at this lesion, nodular lesions in the neck. What is this? This is bacillary angiomatosis. As the name suggests, it's a bacterial infection actually. Which bacteria? We have studied in micro. This is Bartonella hensleyi, the same that was causing cat scratch. So Bartonella hensleyi, this is a bacteria that you can stain with Warthin-Starry stain. Okay, so this is bacillary angiomatosis. On the other hand, when you see these nodular red lesions, violaceous papules is what they will describe, and you see these spindle cells here. What is this? This is Kaposi sarcoma. Very, very important. So Kaposi sarcoma is associated with HHV8. So we saw HHV7 rosea, HHV8, Kaposi sarcoma. The treatment here, you can try immunotherapy like interferon alpha. So Kaposi sarcoma, HIV/AIDS, violaceous papules, spindle cells. PYQ, what is associated with HHV8? One, Kaposi. Second, Castleman's disease. So Castleman's disease is proliferation of lymph nodes but around blood vessels. Can you see there's a blood vessel and there are all of these germinal follicles? This has been given the name of lollipop sign. So this is what is Castleman's linked with HHV8, and you have primary effusion lymphoma. So this was asked as all except. So all are linked with HHV8 except the fourth option here was human T-cell leukemia. But that's HTLV. There's a virus for that, right? So these are three things with HHV8. Then you can see this, we've studied this in surgery as well. Chronic long-standing lymphedema over years now becomes lymphangiosarcoma. So this is either an angiosarcoma or a lymphangiosarcoma. You see these reddish papules in the limb, right? You can see swelling associated with lymphedema seen with axillary lymph node clearance, right? So this is what we call as Stewart-Treves syndrome. Very commonly asked question, Stewart-Treves syndrome. Then we look at a few systemic disorders. Here mainly I want to discuss TB. So the most common form of cutaneous TB in adults is going to be lupus vulgaris. Again, gross misnomer. Neither is this related to SLE. It is common. So this is not SLE. So this is lupus vulgaris, which is a cutaneous TB. So you see this central scarring here, and if you take a slide, you are going to see this apple jelly nodule. So diascopy shows apple jelly appearance. So central scar is cutaneous TB. Central clearing. So let's do this pattern. We have already studied is tinea, right? Ringworm. Central crusting is Kala Azar. So this is what we see in PKDL, post Kala Azar dermal leishmaniasis, central crusting volcano sign. So K and K, clearing you know is ring, scar, TB leaves scars. So this pattern is done. Now, very important NEET 25 question. Lupus vulgaris, it's paucibacillary. What does that mean? That if I do a skin biopsy, am I going to see acid fast? No, I am not going to see acid fast bacilli. What I am going to see are granulomas, right? So the investigation of choice for cutaneous TB is skin biopsy, but that's to look for granulomas, not the bacilli, right? So that's one. Then what do you see here is the most common form of cutaneous TB in children. This is where you have, these nodulo-ulcerative abscesses which tend to rupture. This is scrofuloderma, meaning there is this cooled abscess. There's a huge lymph nodal abscess which may rupture outside. But what is this? This is what we call as a tuberculide. Remember, we studied erythema induratum of Bazin? That was a tuberculide, which is a hypersensitivity to TB. You are not going to see TB bacilli here. It's a hypersensitivity. So this is what is lichen scrofulosorum. So this is where, again, because it's a hypersensitivity, type 4 hypersensitivity to TB, if you do a biopsy, you're not going to see anything. It's a hypersensitivity. The other context in which this is asked is it's not a true lichenoid reaction. It is a hypersensitivity to that. Alright, so this is what is a tuberculide. Now we talk about neurocutaneous syndromes. So this is where I'll tell you all the genetics here and a few findings which are important. So let's do all of them as a table. Neurofibromatosis 1, NF2, tuberous sclerosis, von Hippel-Lindau, Sturge-Weber, ataxia telangiectasia. That's what I'm discussing. So inheritance of all of them is autosomal dominant except S. S is S. It is sporadic and ataxia telangiectasia is recessive. So that's done. The genes. So in NF1 we have 17, 2 for 22. Tuberous sclerosis is 9 and 16. Let me tell you the genes. So NF1 is neurofibromin. 22 is Merlin. 9 and 16 go in alphabetical order. So this is Hamartin and Tuberin. So go in alphabetical order. Hamartin, Tuberin. Von Hippel-Lindau, this is where the gene is chromosome 3 VHL gene. Sturge-Weber is GNAC, not GNAS. Okay, so S is not S. And ataxia telangiectasia, the chromosome in Sturge-Weber is 9. Ataxia telangiectasia, chromosome 11. Right? So these are the chromosomes that we have to remember. Little volatile, you have to revise this. Let's do the salient features. So neurofibromatosis 1, NF1 is, as the name suggests, you are going to have neurofibromas along with a bunch of other features. So let's see the criteria. So this is where the hallmark here is the cafe au lait macules. As the name suggests, these are hyperpigmented macules. So you see 6 or more such macules, which the size criteria is less than 5 for prepubertal, more than 15 for postpubertal. That's not important. Just remember 6 or more are needed. Additional point here, these cafe au lait macules in NF1 are going to have regular margins, and this is what is called as coast of California. This is versus the cafe au lait macules we'll study in McCune-Albright, where you also have fibrous dysplasia. That is called as coast of Maine, irregular appearance. You also need axillary or inguinal freckling, that is called as Crowe's sign. There are neurofibromas, either 2 or more dermal or 1 or more plexus involved, plexiform. In these neurofibromas, you have something called as buttonhole sign, meaning if you press on it, the central part is depressed. Then you may see optic nerve gliomas, Lish nodules, which are iris hematomas. There can be sphenoid dysplasia, very important. So you can see here on the left side, this is a CT 3D image that you are seeing. The sphenoid is not there. So this is what is called as the bare orbit sign, sphenoid dysplasia. Do remember this. Then there can be tibial pseudoarthrosis, where the tibia forms a joint, a pseudo joint between the two. And there could be bone lesions and family history. So not everything needs to be remembered. Just remember cafe au lait macules, neurofibromas, sphenoid dysplasia. So this is the NF1 criteria. NF2 is very simple. You need either bilateral vestibular schwannomas or one vestibular schwannoma with family history. Apart from that, it has Miss-Me features. Miss-Me features means multiple inherited either schwannomas, meningiomas or ependymomas. So you can remember Miss-Me. Tuberous sclerosis, as the name suggests, has multiple hematomas, right? Everywhere in the body you have hematomas. Special treatment mentioned, we can use mTOR inhibitors like sirolimus, everolimus. So these can inhibit the hematomatous growths. Just see what are the major features. So this is what is also called as Bournville's syndrome. Okay, so Bournville's disease is what is tuberous sclerosis, and the triad was described as epiloia. So epiloia is epilepsy, low IQ, and adenoma sebaceum. So adenoma sebaceum is nothing but these angiofibromas that you have on the face, which is the hallmark of the disease, right? So that's epiloia. Then you may also have hypomelanotic macules, which are called as ash leaf macules. There can be these patches in the trunk called as shagreen patches. Three things in the brain: subependymal nodules. So you can see these chota nodules. A big mass is what is SEGA. SEGA is subependymal giant cell tumor that's frequently at the foramen of magnum. And you may have these tubers, cortical tubers. So you can have nodules, you can have SEGAs, and you have cortical tubers. This was asked, it's a very old AIMS question somewhere when I was preparing. So what is minor is these white matter lines. So that's a minor feature of tuberous sclerosis. Then you may have cardiac rhabdomyomas, kidney, very, very important. Fat containing lesions we'll study in surgery. Angiomyolipoma and pulmonary LAM. LAM is lymphangioliomyomatosis. Apart from that, there are many minor lesions. Don't see that. So major symptoms, if you remember, that's fine. So remember AML and LAM. Remember 3 brain lesions. Remember adenoma sebaceum, right? So that's tuberous sclerosis. VHL, we will study again in surgery. So this is where the triad has been asked. Clear cell RCC. You can see pheochromocytoma, and you can see hemangioblastoma, particularly more commonly in the cerebellum. So cerebellar hemangioblastoma, pheo RCC. Serge Weber, very important. You see this calcification in the skull. This is what is called as tram track skull appearance, and there is this port wine stain that you see here in this baby, also called as nevus flammeus, and this is what is most commonly along V1 trigeminal territory. And you may also have congenital glaucoma. So that's the triad here. So this is where you have tram track, port wine, and congenital glaucoma. Ataxia telangiectasia, everything is in the name. You have ataxia and you have telangiectasia. This is also associated with immunocompromised state. So this is a little extra edge. Don't get questions very commonly, but this is also a very commonly missed topic. So might as well finish it once and for all. Last few things which are, just miscellaneous 2-3 slides that we need to do. So the first thing, the lesion. This is what is called as a discoid morphology. What we call as a discoid morphology is the raised center. So this is what is a discoid or a nummular form of eczema. Then you can see discoid lupus erythematosus. So this is what is again more in the face photo exposed area. The center part is raised. This picture has been asked in the past. Then this is what is called as salt and pepper pigmentation, and this is what has been associated with scleroderma. This is also a PYQ. Then this is what is seborrheic dermatitis. Seborrheic dermatitis means essentially everywhere that you get dandruff-like plaques. So you can see it in the scalp, you can see it in the nasolabial folds, the upper part of chest. So these are the common areas which are involved in seborrheic distribution. Cradle cap is a manifestation that you see in newborn babies. Then let's look at a few nails. Buse lines. So they'll give you the name. You can't just see the image and answer here. So Buse lines are what are also called as growth arrest lines. Mees lines, are seen with arsenic. Muircase bands, M for M, is malnourished babies or malnourished whoever, right? So this is associated with low albumin. L is Lindsay. Remember, L is not L. So this is what is associated with renal failure. They are also called as 50-50 lines. Means you can see almost half of the nails here. This is white and this is not white. So 50-50. Whereas this is 90-10. You can see 90 is white, 10 is not white. So these are Terry lines. Terry lines, Terry liver failure. That's how you can remember. So L is not L or Terry liver. So this is Terry lines. So these are a few nail lines. They can ask you match the following. Never been asked so far. Then we have ichthyosis spectrum. So this is what is the most common ichthyosis, something that we talked about, ichthyosis vulgaris. This is where we do not have filaggrin, remember. So because filaggrin is not there, dry fishnet scales, the limbs are commonly affected. This one is lamellar ichthyosis, where there is a membrane, or colloidal baby is the other name. So colloid is a membrane, lamella is a membrane. So colloidal baby, and the scales are present on the trunk. This is epidermal transglutaminase 1 defect. Remember, epidermal transglutaminase 3 was dermatitis herpetiformis, also associated with ectropion. If you don't have this membrane at birth, but they tell you just trunk, right? So trunk pe scales, all right, only trunk pe scales, that is X-linked recessive ichthyosis, and that's a defect of steroid sulfatase, all right. And then this is the most severe form of ichthyosis called as harlequin baby. Look at the thick shell. Most of these babies don't really survive because, they have absolutely, complete peeling of skin once this happens. So a lot of third space losses. So vulgaris, lamellar, X-linked, harlequin. This was asked. NEET 25. This is lichen sclerosis, where, and this is something which is a favorite of INI examiners as well. They'll give you dry, introitus, dyspareunia would be an history. So a lot of fibrosis happens around the introitus in females. This is dermatitis artifacta. When you see that the non-dominant hand is affected and lesions which do not really fit into a territory, these have been produced, right? So self-produced artifactual lesions. When you see such a hypopigmented patch, very common in the Asian subcontinent, hypopigmentation on the face, what do you think of? You think of two things. One, it could be indeterminate type of leprosy. Another DD here is pityriasis alba. Alba matlab white. So indeterminate leprosy, the buzzword would be sensory loss. P alba would be scaly. There would be scales. It would be itchy, right? And there could be association of atopy. There is no sensory loss. So this is indeterminate leprosy, good prognosis. Pityriasis alba also very good results on its own. So this is hypopigmentation with face. NEET 24 question, you have a focal, fibrosis, and you can see how it looks like a box. There is so much fibrosis. So this is where you have fibrosis. This is morphia. So morphia, this is localized scleroderma, not scleroderma, remember? So this is morphia, and this sign is called as a box sign. Two hair conditions, INI PYQ. So where you have this bamboo hair association with atopic dermatitis, ichthyosis, this is called as Netherton syndrome. Whereas this has been asked previously, tiger tail syndrome. This is trichothiodystrophy. It is also the same spectrum as xeroderma pigmentosa, where you have a nucleotide excision defect, and this is this huge scary name pibidis, where you have all of this association. Don't even read it. So Netherton trichothiodystrophy. One old PYQ, methyl isothiazolinone, is what is associated, as a preservative in cosmetics. They just asked what is the role. It's a preservative, can induce allergic reactions. Now talking about HPV. So the final thing we have to do are these warts. So these are anogenital warts. Let's start with that. So anogenital warts are called as condyloma acuminata, not lata, because lata has syphilis. So lata is syphilis, acuminata is HPV. The HPV that causes it is 611. All right. High risk HPVs 16, 18, 31, 33, 45, 52, 58. So how to remember? These two you know, these two you know. Now remove 5, 4 twos are 8. So that's how you'll remember these. And why is it important? Because these 9 are what are the part of Gardasil 9 vaccine, nonavalent vaccines, and these are the ones which can turn into cancers. Okay, but we may have non-neoplastic HPV, so plantar warts in the foot. So what are the causes of plantar warts? So plantar warts is HPV 1 and 2. Then you have verruca vulgaris. As the name suggests, this is most common. So this is what is a common wart, right? So verruca vulgaris, take it from 2, 4 and 27. If asked to choose one, choose 4. Verruca plana, very common. So this is where you don't see the warty appearance. These are flat, plana. So this is 3 and 10. Focal epithelial hyperplasia seen in the mucosa is 13 and 32. So these are few warts. You want to remember this volatile hair, you will have to revise. Now, for warts, you can use podophyllin or imiquimod. Imiquimod is what is an immunomodulator, as the name suggests. Its target is toll-like receptor 7 agonism. But in pregnancy, you can't use these two drugs. So what are safe in pregnancy? This is a PYQ, cryotherapy. So for genital warts, any other warts, you can use cryotherapy or you can use TCA. That's also safe in pregnancy. So this is about warts. So this completes dermat. It's like pretty large for a short subject, this video, but then I've literally covered everything which you need, right? So this should be the one-stop shop. No need to supplement with anything whatsoever. If you do this much, you can solve any question that they can ask you from dermat, right? So thank you so much, and I'll see you all soon.